morning, everyone. Welcome to the last day of activities for this second international symposium. I greet all people who are video streaming, and we will be starting the activities of today with a very interesting talk from Mark Sulkowski. Dr. Sulkowski, he was yesterday with us. He is Associated Professor of the School of Medicine of Johns Hopkins University, USA, where he is the Medical Director of Viral Hepatitis, Infectious Diseases, Gastroenterology, and Hepatology. He's an internist by the University of Duke, North Carolina, and he has some training on infectious diseases by the School of Medicine of Johns Hopkins. Doctor is going to talk today about new perspectives in steatotic hepatic disease related to metabolic dysfunction and HIV. Thank you, Doctor. You have the floor.
Well, good morning, and thank you. I'm pleased this morning to talk about a different topic, that is metabolic liver disease in people with HIV. You'll note that I did not call this fatty liver disease, and I'll talk about a very recent change in the name that we use to describe this condition of steatosis or fat in the liver. It represents a major shift in our thinking, and one for which there's a strong rationale. So I'll talk about that, and then I'll talk about the issues related to steatotic or fatty liver disease in people with HIV. So I'll start by describing a patient. This is a 55-year-old man with long-standing HIV. He has type 2 diabetes and hyperlipidemia, and is referred for elevated liver enzymes. His ALT is 55. He is negative for hepatitis C and B, and he does drink alcohol 1 or 2 drinks a day. You'll see that he has an elevated BMI with central obesity, and his liver stiffness score by elastography is relatively low, but still 6.8, and he has a CAP score, a measurement of fat in the liver, at 341, which is consistent with severe steatosis. So the first thing I wanted to talk about was a study that we recently published from the ACTG, or AIDS Clinical Trials Group, HALO cohort, where we looked at 662 people with HIV. We selected them because they did not have HIV-CV, they did not have Hep B, and because they were not using alcohol. And over 4 years, 2/3, 2 out of 3 had an elevated ALT, and 1/3 had consistently high liver enzymes. The figure or the table shows that these were largely associated with metabolic factors, things like elevated BMI. There was also some incident or new infections with hepatitis C and B that came out. But when we finished the analysis, it was clear that metabolic factors were driving these elevated liver enzymes in our patient population. So I mentioned the outline. I'll talk about the new definitions, the epidemiology, some information about how we should be screening and diagnosing steatotic liver disease, and then I'll touch on treatment that is moving relatively quickly. So the first thing I want to highlight is the very recent renaming of NAFLD, or non-alcoholic fatty liver disease, and this was done by 3 major societies as well as 70 endorsing societies. So this was a global initiative to rethink the idea of fatty liver disease. So they conducted a Delphi process. This was a series of consensus building. There were a couple of goals I'll highlight. They wanted to reduce stigma. The notion of calling this fatty liver disease carries a stigma with it where people are labeled. And as we know from our work in HIV, stigma is an important factor that prevents us from delivering effective health care. The second major point was that the previous definition ignored alcohol. It assumed that people were either had metabolic factors or they drank, but the two never intersected. And of course, we know that they do intersect. People with metabolic factors may also drink alcohol. And the other major point was they wanted to align with what our cardiology colleagues have accepted as cardiometabolic risk factors. Wanted to be consistent with that. And these are the cardiometabolic risk factors. So to have metabolic liver disease, you have to have one of these: elevated BMI, evidence of diabetes or elevated glucose, high blood pressure, hypertriglyceridemia, or a low HDL. So one of these factors has to be checked off. These were also applied to children, but I won't touch on that. I don't expect you to read this slide, but I wanted to highlight that the American Heart Association has officially labeled metabolic-associated fatty liver disease as a cardiovascular disease enhancer. So if you have a patient where you've calculated their risk for heart disease, and they have evidence of steatosis in the liver, that increases their risk. So they need more aggressive cardiopreventive therapy. So this is the algorithm they developed for steatotic liver disease. Over to the left of this slide is metabolic dysfunction-associated liver disease, and that's where there's really very little, no evidence of alcohol. Someone who's not drinking, and they meet those metabolic criteria and have evidence of steatosis in the liver. In the middle is this intersection where you have both factors that are metabolic as well as alcohol intake. And you can see the spectrum ranges from mostly metabolic to mostly alcohol. And then there's alcohol, and then other categories which are more cryptogenic or unknown. So it's the idea of incorporating how much a person is drinking into this formula. So this shows the continuum of concern. A lot of people with and without HIV have steatosis. Some of those people progress to what's now called MASH. That replaces the term NASH, and that's where there's fatty liver plus evidence of inflammation and hepatocyte or liver cell ballooning. Now, I'll come and talk about liver biopsy, and it's really these people with MASH that progress to cirrhosis. And once cirrhosis develops, it's a life-threatening medical condition that can lead to decompensation and liver cancer. There was a recent presentation at the American Liver Meetings a couple of weeks ago where in the United States, metabolic-associated liver disease is now the #1 reason for liver transplant. So the liver fibrosis score, how much damage or scarring of the liver, predicts whether someone will develop variceal bleeding and other complications, liver cancer, or die. And over to the F4 category, that's cirrhosis. These patients have a very high risk of liver mortality, cancer, or death. But this paper published in the Journal of Medicine really didn't adequately account for alcohol. And this recent publication redoes that type of analysis, but this time factoring in how much the person drinks. And I won't go through this entire slide, but what it looks at is people that have alcohol on top of metabolic-associated liver disease have a much greater risk of liver decompensation. And you can predict somebody's potential outcome by assessing both metabolic factors as well as alcohol. There's also, this is true of people with low liver stiffness as well as people with high liver stiffness, shown up at the top here. So this is a decision support tool that was developed, and the idea is you walk down this tool. Does the person have fat or steatosis in the liver? If they do they have cardiometabolic factors, yes or no? And then asking the question, what about alcohol? Now, I will comment that it is important to assess alcohol carefully because people often underreport alcohol, and doing things like a formal audit score can be quite helpful. Now, let's move to talk about people with HIV. Now, I've kept the old terminology because when these studies were done, they weren't looking at these new definitions of metabolic disease. They were using NAFLD. So when you look at the general population, it's estimated that roughly 25% of people have some definition of metabolic-associated liver disease. In HIV-infected persons, that's as high as 35%. And the proportion of those that represent steatohepatitis, or MASH, or NASH on this slide, is higher. So a higher prevalence of fat and more significant liver inflammation. This slide summarizes a series of studies and looks at how they measured steatosis. Now, most of these are not using liver biopsy, and I'll comment that to diagnose MASH or NASH, liver biopsy is still recommended, and that presents some issues since that is not frequently performed in our patient population. But you'll see the prevalence of steatotic liver disease ranges from 52% to as low as 9%, and these numbers are really quite high. So we'll think a bit more about the implications of this. So why is there more evidence of fat in the liver of people with HIV? And there's a number of potential factors. Certainly the same metabolic factors that have been reported with people without HIV are present. We're well aware of the concerns about diabetes, hyperlipidemia, cardiovascular disease. But there may be some other issues related to antiretroviral therapy that can influence fat in the liver. I won't talk about these older drugs, but the drugs we used in the early or late 1990s, didanosine and D4T or stavudine, caused fat in the liver. There may be other contributions that we'll touch on with respect to fat in the liver. There's also concern that HIV itself may contribute to steatosis or fatty liver disease, although these factors are not well understood at this point in time. So the traditional factors in people with HIV are prominent. In this study, it looked at the degree of steatosis in the liver from none, mild, moderate to severe, and looked at waist circumference and BMI. And not surprisingly, the greater the waist circumference, the greater the body mass index, the more likely the person was to have more severe fat in the liver. So certainly assessing body weight, assessing waist circumference can be important in working up patients for metabolic-associated steatotic liver disease. Now, what about antiretroviral therapy? There's been a number of studies that have focused on this, and this is a large multi-center cohort called RESPOND that looked at more than 14,000 people, and of these, a high percentage had an increase in their BMI or body mass index by more than 7%. And what they looked at was risk factors. And what they showed was that there was some association with drugs like tenofovir and drugs like integrase inhibitors. There was also an association with black race, as well as having a low BMI before starting. But the story is not entirely clear, and there appears to be, on the right of this slide, differences between men and women. If we look at men down below, switching from TAF to TDF, no change in weight, whereas among women, there did appear to be some change. So this interaction, if you will. I mention this to say that the story of antiretrovirals and weight gain is really not so simple. Some of this is return to health. Some of it has to do with appetite suppression of drugs like efavirenz or TDF, but it's not quite so simple. So we are not recommending changes in antiretroviral therapy simply because someone has gained weight or has steatosis in the liver. Following guidelines for the appropriate antiretroviral therapy is what is recommended, but it is an area of discussion. This slide is taken from the HIV Swiss cohort, a study of 416 patients, and what they found was that the prevalence of severe steatosis was 34%, again quite high. And when they looked at risk factors for steatosis and the prevalence of metabolic-associated fatty liver disease, it was as high as 43%. And here they did see an association in this study with nifalfenamide. But I'll come back to this point that what you see is really driving this. The strongest risk factors are things at the top of this, like body mass index. So certainly when we think about what can we change for a patient, I'll emphasize again, we don't recommend changing antiretroviral therapy. Instead, as I'll talk about, we recommend focusing on healthy eating, healthy activity, and I'll talk a bit about pharmacologic therapy. Now, why is this important? There's a couple of studies, and this one was a liver biopsy study that suggested that compared to people without HIV, people with HIV had a more rapid progression of fibrosis or scarring of the liver. So if you think about some of the studies I talked about earlier, liver scarring or fibrosis predicts whether or not you'll develop liver failure, liver cancer, or death. So we don't want patients to progress from no scarring to mild scarring to moderate scarring to cirrhosis. We want them to stay with minimal scarring. Because the fat in and of itself in the liver, the steatosis, if it's not leading to scarring, is unlikely to cause liver cancer or liver death. And here in this study, over a period of 12 months, you can see the rate of progression of scarring in the general population was much lower at 0.03 compared to people who are HIV infected. And you can see that more people progressed in this category on paired biopsy. So patients with HIV, just like we saw with hepatitis C and B, progress more rapidly. I'll come back to this point of cardiovascular disease. This was a study published that looked at cardiovascular disease risk in people with HIV. And what they found was that independent of other factors, that metabolic-associated steatotic liver disease was independently associated with a higher cardiovascular risk score. So I won't talk about the REPRIEVE trial, but when we think about people who may benefit from taking a statin, I would put people with steatosis in their livers as a potential group to consider benefiting from statins because it is an independent cardiovascular risk. So based on the high prevalence of steatosis in the liver of people with HIV and on the potential for progression to cirrhosis and heart disease, it makes sense to consider the diagnosis in patients. So most of us are using clinical parameters. Is the ALT level high? And one comment I'll make is that the ALT level should not be elevated in people with HIV. Many of us are used to seeing high ALT levels because of all the things that affect the liver. But any person where the liver enzyme ALT is high warrants a workup. If the patient has a high BMI, a high waist circumference, diabetes, hypertriglyceridemia or high triglycerides, or low HDL, they now have one of those cardiometabolic risk factors. The next step is non-invasive testing. There's a number of different parameters listed here. I personally favor the FIB-4 because it gives us a pretty good estimate and has been studied literally thousands of times across all different types of liver disease. FIB-4 includes the patient's age, the ALT, the AST, and the platelet count. And it will give you an idea of whether or not they have fibrotic liver disease. The next thing is liver imaging. Ultrasound can certainly miss liver fat, but it can also show liver fat, so ultrasound is reasonable. But the recommended approach is a transient elastography or fibroscan. The CAP score, which stands for Controlled Attenuation Parameter, is increasingly used. Now, liver biopsy is recommended for some people, but we rarely do this in our practice of caring for people with HIV, in part because it's most used today for enrollment into clinical trials. I'll talk about that in a minute, but if you're not planning to put your patient in a clinical trial, if they have a high ALT, you've ruled out other causes like hepatitis C and B, and they have steatosis on their liver or a high CAP score, it is reasonable to assume that they have MASH or steatotic liver disease without a biopsy. Now, the liver biopsy criteria are shown here. I'm not going to walk through these, but one of the reasons why it's been hard to develop drugs or new medications to treat metabolic steatotic liver disease is because the endpoint relies on biopsy. And the liver biopsy criteria are listed here. You have to have both fat in the liver as well as inflammation or ballooning, and then there's scores on fibrosis. The problem with biopsy is there's tremendous sampling error. It's a small piece of the liver, and in the placebo patients in clinical trials, they often have improvements just like the active treatment, which makes it difficult to tease out drug effect. So this is just a discussion of the controlled attenuation parameter. This is a software update on the FibroScan that can give you a score, and the recommended cutoffs for steatosis are really above 268, a CAP score. And what this is measuring is how the elastic wave elastography produces bounces off liver cells. If the liver cell has triglycerides or fat in it, the wave will be attenuated. If it doesn't have fat inside of it, the wave pattern will look different. So CAP score has been fairly well validated and is what we use in our clinical practice to assess fatty liver disease. So this is from Dr. Ken Sherman in Cincinnati, and just recommending the approach. And what he's recommending is to assess someone's alcohol that we've talked about in the top. You would then assess with transient elastography or hepatic elastography to develop a CAP score and then decide on management. Now, with elastography, the liver stiffness score is the one that aligns with fibrosis. People with low liver stiffness scores or low fibrosis generally aren't at risk to progress, whereas people with higher scores need greater attention and consideration of interventions, both non-pharmacologic and pharmacologic. So the American Liver Society recommends that everyone start with a non-pharmacologic approach to metabolic-associated steatohepatitis. That's weight loss, and I'll talk about some studies that show even a 5% decline in body weight can lead to improvement in the liver disease, including less steatosis and less fibrosis. And then I'll talk a little bit about exercise, because physiologic exercise has effects on steatosis beyond that of simply weight loss. I'll also talk a little bit about bariatric surgery. Bariatric surgery has been demonstrated to show benefits in people with metabolic-associated steatotic liver disease, but is a major intervention, and I'll point out has not been well studied in people with HIV. One of the things I think is really a high area of emphasis is physical activity. And this figure shows the abundant and multiple benefits of physical activity when it comes to liver disease. So really encouraging your patients to exercise, walking daily, as part of their routine daily activity is incredibly important. Now, it's something that's also quite difficult, but there are studies that show that if a clinician prescribes exercise, that increases the likelihood of a person engaging in activity. So it's worth having that conversation, and certainly there are benefits with respect to heart disease and other factors like diabetes, hypertension that are also able to be obtained. Now, this slide is a really interesting study that looked at liver biopsies and then weight loss. And what you can see is the amount of weight loss in the column over here, and then the improvement that they saw in terms of the NASH resolution. So greater than 7% weight loss, NASH resolution occurred in 64 to 90% of patients. So weight loss in and of itself can have significant improvements, and the benefits we're seeing with weight loss as small as 3% of the person's body weight. And this study was done with liver biopsy, which is considered the gold standard to show improvements. So that leads me to potential medications. Now, I want to emphasize that the approach to weight loss should not start with medications. Increasingly, certainly in the United States, we're seeing an uptick of glucagon-like peptide-1 analogs. Semaglutide is one of these that's being used increasingly. There is a study that was presented at CROI that has looked at the use of this drug for steatotic liver disease in people with HIV. I can't share the results of this yet, but it will be presented at CROI in 2024. The study that I'm showing is the phase 3 clinical trial in people without HIV, 961 patients with elevated BMI, and what you can see is a substantial reduction in weight, which could lead to benefits with liver disease. Now, this is not without concerns. Patients in these using semaglutide and other agents of this class do have nausea. They also have daily injections of this agent. So this is not something we're widely using or recommended, and it is extraordinarily expensive at this time. But I do look forward to the results of the Slim Liver study, the one I mentioned that will be at CROI, to see where this fits in. But currently, our best approach is to emphasize healthy eating and healthy activity. I'll talk just briefly about bariatric surgery. If you look in the medical literature, there is not a lot of information about the role of bariatric surgery in people with HIV. I think there's important questions about whether or not bariatric surgery could impact the absorption of certain antiretroviral drugs. And to date, that's not really been studied. In a couple of publications, number one, it's been uncommon, and number two, there was no concerns among 346 patients that underwent bariatric surgery in this retrospective analysis. So the criteria or qualifications are listed over to the right, and I think it is reasonable to consider in people with BMI over 40, people with BMIs over 35, with diabetes, cardiovascular disease, sleep apnea, MASH or NASH, or other concerns. But this is something that is really, in my view, not the first step we want to take with patients, but it has been shown to improve liver disease. Now, I've talked about alcohol early on. We see very high rates of alcohol use among patients with HIV in our clinic population. We did a study that I won't talk about where people did an audit. So we asked them questions, how much do you drink? And of the people that told us on audit that they didn't drink alcohol, we then ran a biologic marker of alcohol exposure called PEth on a drop of whole blood. We found that 46% of the people who reported to us that they were not using alcohol had evidence of alcohol in their blood for a period of 14 days prior to that blood test being done. Why do I mention that? Because when you're evaluating someone for liver disease, almost every patient knows that the correct answer for alcohol is none. So there is a bias to underreport alcohol when you're talking about liver disease. So we need to talk about alcohol in a way that is supportive, non-stigmatizing, and one that's focused on engaging health. What this study shows is that people with MAFLD certainly have worsening liver disease if they use alcohol. So these are the guidance for pharmacologic therapies. As of today, there are no approved treatments globally for metabolic-associated liver disease. There is a recommendation for pioglitazone. That's not something we use very often. There are studies supporting the use of vitamin E for patients without diabetes and without cirrhosis, but neither of those is FDA approved. So this is now the old study done a long time ago called PIVENS. I won't focus on the pioglitazone because one thing you'll see with pioglitazone is that the weight of the patient increased considerably over here. But what you'll see with vitamin E, the ALT level declined. And that's shown up here with the ALT dropping. And then on liver biopsies, they also had improvements in resolution or improvements of NASH. So I do have some of my patients with HIV and suspicion for metabolic-associated steatohepatitis taking vitamin E every day because it is relatively safe and relatively inexpensive, and there are clinical trials showing its benefit. There is one uncontrolled study. This was a phase 4 study that looked at patients with HIV, a CAP score of greater than 248, that may be a little low. They had some metabolic factors, and they were treated with vitamin E at a dose of 800 IU daily, which is what was used in the PIVEN study. And they showed resolution or improvement in ALT and CAP scores. Now, this is an uncontrolled study, and to my knowledge, there are no randomized controlled trials for people with HIV. But if you're looking to add a pharmacologic intervention, vitamin E 800 IU daily is something that there is evidence-based, and it's recommended for people without diabetes and without cirrhosis. There is data to support the use of tesamorelin. This agent is something that's used relatively infrequently, but they did conduct a multi-center, double-blind, placebo-controlled trial of people with fat in their liver by MRI scan. And what they were able to demonstrate is that there was a reduction in liver fibrosis progression and liver fat in people who took tesamorelin. So there was a reduction both in the fat score, and then over to the right of this slide, a decrease in the progression rate of fibrosis, suggesting that this may be a useful agent. It's rarely used in our clinical practice because of high cost, the need for injections, but it is interesting that it's one of the few drugs in which there was a carefully designed, randomized controlled trial in people with HIV. There are multiple drugs under investigation for metabolic-associated steatotic liver disease. These drugs focus on preventing fibrosis or scarring. They focus on various metabolic factors. I will point out that there is a problem with focusing just on the liver. Many patients with metabolic-associated steatotic liver disease die of heart disease. So it really is important not to look for a pill or an injection to be the solution to metabolic-associated liver disease. It's important to focus on healthy eating and healthy activity. Many of these drugs have already failed in clinical trials. They failed because they didn't work, but they also failed because of liver biopsy and because the pathogenesis is different for different patients. I'll mention one because this is the first drug to have met its primary endpoint in phase 3 clinical trials and is being submitted to regulatory authorities around the world, particularly the US application went in the fall, and there is a action date in March 2024. If everything goes according to plan, this may be a drug that's approved for the treatment of metabolic-associated steatotic liver disease. Now, I'll comment that the clinical trials did not enroll people with HIV and will have zero data on whether or not this drug is safe, tolerable, effective in people with HIV. But in this phase 3 clinical trial, they took people with biopsy-proven NASH or MASH. They also had to have significant fibrosis, and they randomized them to one of 2 doses of resmetirom, which is a thyroid hormone receptor beta agonist. It turns out the liver cells have this thyroid hormone receptor beta and that the thyroid hormone plays a role in the health of the liver. So this does not have thyroid activity the way, say, thyroxine does, but acts on the liver. They had what is the traditional endpoints. The regulatory authorities globally have required biopsy-proven reduction in that fibrosis score I shared with you earlier, or the NASH score I shared earlier, as well as fibrosis improvement by at least 1 stage. And what they showed is that at both doses, at 52 weeks or 1 year, patients assigned to the beta thyroid agonist did better than patients assigned to placebo. Excuse me. Based on this, we anticipate this will be regulatory approved. Now, I would emphasize, again, this has not been studied in people with HIV. So to summarize, unfortunately, as my throat dries out, the people with HIV and metabolic-associated site liver disease, there is a high prevalence, which warrants that we investigate the liver in these patients. Excuse me, my throat has dried out. And because of this, I think the simple approach is if a patient has an abnormal ALT, if the ALT is high, that's not normal. That requires an evaluation. Hep C and B are serology testing. If that's negative, think about alcohol and fatty liver and go down that algorithm of metabolic-associated steatotic liver disease. And ask the question, is it pure metabolic disease? Is it mixed metabolic alcohol, or is it pure alcohol? And consider liver elastography if available. I also would highlight the FIB4. There are no approved treatments, but every patient with metabolic-associated steatotic liver disease can benefit from a focus on weight loss, increased physical activity, as well as alcohol cessation. We certainly need more clinical research. I'll point you to the clinical trial called Slim Liver with semaglutide at CROI. And we need patients with HIV to be included in clinical trials. This happened with Hep C, it happened with Hep B. Patients with HIV are excluded from clinical trials, and in the era of highly effective antiretroviral therapy, there is really no justification for that. So unfortunately, we may have the first drug approved for metabolic-associated steatotic liver disease, and we'll have no data on its safety, tolerability, and efficacy in people with HIV. So we are working to implore sponsors to enroll patients with HIV in these studies. Thank you for your attention.
Bien, muchas gracias por la presentación al doctor Galán. Sí, perdón, al doctor Sulkowski. Sí.
Would you like to ask a question? Because if you have questions, now is the right time to ask them. Do you have any questions for Dr. Sulkowski? Yes, I have a question.
Between metabolic liver disease, HIV, and autoimmune markers, biomarkers?
I'm not aware of studies of autoimmune disease markers being in people with HIV. We've looked at that over time, but the incidence of autoimmune hepatitis with HIV appears to be quite low. Doesn't appear to be a major factor, and I don't believe contributes to the metabolic factors.
Thank you very much. And this is for you.
Oh, thank you
very much.
Okay. Thank you very much.
Un aplauso para el doctor, por favor.
So I would like to provide you with a follow-up of our agenda now. There's a very important element by a speaker that joined us yesterday as well. Now we are going to talk about low-level viremia management. We have Dr. Joel Gallant. Joel Gallant, as you very well know, he is a benchmark in the treatment of HIV. Currently, he's an executive director of medical affairs on HIV at Gilead. And we know that he has published many articles about it. He is a benchmark in HIV, so please let's welcome him with a big round of applause.
Okay. Gracias. Buenos dias. It's good to be back. And now in your program, it talks about, my topic is low-level viremia. But the original topic I was given was a little bit broader than that: resistance, low-level viremia, and transient virologic escape. I don't think there's enough to say about low-level viremia in 40 minutes. So I'm going to talk a lot about resistance, and my apologies that I didn't realize that you'd be hearing from Dr. Soto yesterday on the same topic, but I think, you know, there'll be different focuses, and it's always good to hear things again. So this is just a disclaimer to remind you that much of what I say will be off-label. So you know already, of course, that resistance can be treatment emergent, occurring usually as a result of subtherapeutic drug levels or inappropriate regimens, or it can be transmitted when somebody's infected by somebody who has circulating viral resistance. So the relationship between drug levels and resistance has been well described. If somebody has virtually no adherence, is taking almost no medication, there's not enough selective pressure there to select for resistant mutants. And in fact, the wild-type virus can replicate just fine on its own, so you don't tend to get resistance. And obviously, if drug levels are very high, you have suppression of replication. So you don't get resistance because resistance requires replication. It's in this intermediate zone that we worry about, where people have enough drug levels to be selective, but not enough to suppress the virus. Now, in the ideal circumstances, somebody's taking their doses as directed, so their C-min is always well above the EC95, and in fact, that gap between the C-min and the EC95 we refer to as the IQ, or the inhibitory quotient. The higher the IQ is, the more of a buffer you have against resistance. But if somebody misses doses, and especially consecutive doses, then eventually you can get to where the drug levels are falling and eventually fall below the EC95, and that's where you get into the range where you can get selection of resistant mutants. Now, we've talked yesterday about barriers, and there are sort of two types of resistance barriers. There's the pharmacokinetic barrier, which is related to pharmacokinetics of the drug, the half-life, the IQ. And we talked yesterday about, for example, that efavirenz had a very high PK barrier, and that was one of its advantages. But it had a very low genetic barrier, meaning that it only took a single mutation to get high-level resistance. The genetic barrier can roughly be thought of as the number of mutations you need to get resistance, although that's a little bit oversimplified. But we used to have to choose between regimens with high PK barriers or high genetic barriers. We rarely got both. Now, of course, we don't have to choose. Our best regimens have both high genetic and PK barriers, examples being 3-drug regimens that have either a boosted protease inhibitor or a second-generation integrase inhibitor. Cross-resistance is very common within classes. It doesn't tend to occur between classes, but within classes, and this applies to all the drug classes, you see that when you have resistance to one drug, there's variable cross-resistance to other drugs in that class. Now, what are the assays that we can use? Well, the most common is the RNA genotype. When we talk about genotype, that's usually what we're talking about. In fact, when we talk about resistance tests, that's usually what we're talking about. And that's just looking for mutations known to be associated with resistance. There's another type of RNA assay called the proviral DNA assay, also referred to as the archive test. It has two advantages. One, it can be performed in people with undetectable viral loads or very low-level viremia. And two, it theoretically is supposed to be able to tell you about mutations in the archive. In other words, non-circulating mutations, mutations that were archived there maybe years or even decades ago that you would not be able to pick up from a standard test. And then there's a phenotype assay, not widely used anymore. It's quite expensive, it takes a long time, but it is a more direct and quantitative measure of resistance. It can tell you, it can rank, for example, protease inhibitors in terms of their degree of resistance, rather than sort of giving you yes, no, or maybe answers. But it's not widely used. So how do we interpret genotypes? There's lots of ways. You can just trust the lab you're using to interpret it for you. though I prefer to use the Stanford University database. It's a free online website where you enter the mutations and it will interpret them for you, but it also has lots of other information. It tells you about the specific mutations, how they're selected, what effects they have on various drugs. So these are the DHHS guidelines on which resistance assays to use and when. And you can see that in almost all cases, it tells you to use the RNA genotype. The exceptions are in patients who are on an integrase-based regimen. Of course, you should use an integrase resistance genotype. That's more and more being incorporated into the standard genotypes, but in some cases you do have to order it separately. In people with known, suspected, complex resistance patterns, this is where a phenotype may be helpful, and it should always be combined with a genotype. And then proviral DNA, if you have access to it, is for people with undetectable or low-level viremia, especially people who maybe have had complex treatment histories, but you don't have access to their old records, their old genotypes, their old antiretroviral histories. Those are the situations where I would use these assays. The other thing to remember is someone's resistance pattern is not, you can't determine it by ordering one test. It is the sum total of all the cumulative tests they've ever had, plus an analysis of their treatment history. So never fool yourself into thinking, well, they don't have resistance because I did a resistance test and it came back negative. You're not accounting for the fact that maybe years ago they took a regimen they got resistant to, but those resistant mutants are no longer circulating and no longer detectable. So it really requires that you look at the whole picture, their whole treatment history, and all their prior resistance tests. Limitations. So the RNA-based genotype and phenotypes, you have to have at least 500 to 1,000 copies to be able to get a result. That is not true of the proviral DNA. And remember that these tests are generally going to tell you about drugs and drug classes that the patient is currently taking. They're not going to always tell you about drugs they took 10 years ago. So that's the reason that historical review is so important. Now, I know Dr. Soto talked about this yesterday, a prevalence of transmitted resistance by class. This is in the US. Notice the data only go up to 2016, but frankly, the data haven't changed very much since then. About 19% in the US of people are infected with some resistant virus. Most of that is NNRTI resistance. We have a little less protease inhibitor and nucleoside resistance, and very little integrase resistance transmitted, still down around 1%. So people say, well, that makes no sense. Why, when in a time when we don't use NNRTIs anymore, and we use almost exclusively integrase inhibitors, why do we still see so much transmitted NNRTI resistance? And the reason has to do with the effect of these mutations on viral fitness and replicative capacity. So if you look at the right, if somebody has at time 0, they have M184V and they have an NNRTI mutation. What happens to the NNRTI mutation? A year later, it's still circulating, still detectable. Why? It has almost no effect on viral fitness. The virus is perfectly happy with the K103N. It can replicate just as well as it can without the 103N. So there's no selective reason to get rid of that mutation. In contrast, 184V has a very detrimental effect on fitness. So you can see that by 6 months, only about a third of that 184V is still detectable, and by the end of a year, it's virtually all gone. Now, it's not really gone. It's still archived in the reservoir, but it can't be detected. And this is why I think we have to be careful, especially as we're starting to use regimens that really rely on 3TC, like dolutegravir 3TC, because there are a lot of people who have 184V that you don't know about because it can't be detected, but it's still there. So what about the proviral DNA assay? we have some interesting studies from Gilead. The first two, 1844 and 1878, were studies that excluded people if they had a known 184V mutation. So if you see that in their historical record, none had 184V. But we went back and looked at their proviral DNA and found it in 15%. So there were 15% of people we thought had no 184V, but in fact they did. But then later we did a study, 1824, where we required that they have 184 to get in. So 100% of people had it in their record, but we only detected 48% with a proviral DNA. So if you apply that, say, 50% sensitivity to this number here, 15%, that means that this number could have been as high as 30%. So what does that tell us? First of all, it tells us resistance, there is resistance that we don't know about. But it also tells us the proviral DNA is not the magic answer, because it's going to miss half of those mutations that are there that we don't know about. So good news, bad news sort of thing. Now, a little bit about the integrase inhibitors, and this is looking at dissociation half-life, which we know the plasma half-life for bictegravir is the longest among the integrase inhibitors. But what's also perhaps even more important than the plasma half-life is the dissociation half-life. How long does dolutegravir remain bound into this integrase DNA complex? And so you can see that it's longest for wild-type virus. It's longest for bictegravir in green. Longer than for dolutegravir, and much longer than for raltegravir and elvitegravir. And then if you look at the dissociation half-life for a common but particularly bad mutation pattern, 140S, 148H, it's still longer for bictegravir than for dolutegravir. Now this would suggest that there's an advantage of bictegravir for integrase resistance, but this is in vitro data. So we don't have clinical data to say that that's true. We do have data on these patient isolates, all of which had reduced susceptibility to dolutegravir, and we're looking at phenotypic resistance now to both dolutegravir and bictegravir. So if you start over on the left, in yellow, you see there's partial dolutegravir resistance, but still susceptible to bictegravir. As you move to the right, you get more extensive resistance, but still an advantage of bictegravir. And then eventually you get to these more complex resistance patterns where you ultimately have resistance to both drugs. Now notice that the mutation patterns are often, some of them are the same here as they are here, which says something, that there's a diversity or a heterogeneity of phenotypic susceptibility even with the same mutation patterns. And when you see something like this, this is telling you, well, a phenotype might be helpful here, because how do you interpret a combination of mutations when there can be such wide variation in the phenotypic susceptibility? So none of those studies can really address resistance barrier, because resistance barrier can only be determined clinically. The in vitro studies may say, I think this drug will have a high resistance barrier, but to prove it, you have to show that resistance doesn't occur. So you can see here that with BF-TAF, we now have multiple phase 3 studies where we've seen zero emergent resistance to BF-TAF. There have been some resistance in the comparator arms, but it's always been nucleoside resistance, not resistance to the third agent. So these are all high barrier regimens, but you see zero with BF-TAF. In contrast, we have seen some in clinical trials with dolutegravir-based regimens, not dolutegravir with a tenofovir-based backbone, but dolutegravir abacavir 3TC. We've seen 2 cases in our own studies of people who developed 184V on that regimen. And that could be because, remember, when you have a 184V, not only do you lose most of the effect of 3TC, but you reduce the susceptibility to abacavir. In contrast, if there's a tenofovir drug on board, you actually increase susceptibility to tenofovir. And then with dolutegravir 3-TC, in 2 of the early trials where it was given as separate components, we did see dual-class resistance in 2 people who were non-adherent. With dolutegravir rilpivirine, we've seen a number of cases of emergent NNRTI resistance or dolutegravir resistance or both. This is not as widely used now. And then I talked yesterday about cabrilpivirine, where it's very clear that it's a lower barrier than what we're used to. As I said yesterday, about 1% of people on this regimen developed resistance despite on-time dosing. It was a little higher if you were giving the drug every 2 months, a little lower if you were giving it every month. And then here's more detail about that. This is looking at all the cases of failure with cabrilpivirine, and the red font, those are the new mutations people developed as a result of failure. You can see it can be NNRTI resistance, integrase resistance, or both. And then on the right are the risk factors. So ViiV has published 3 important risk factors for failure on this regimen. One is having rilpivirine resistance mutations. The second is having subtype A1 or A6. And the third is having a BMI above 30. And in one case, somebody had all 3 of those risk factors. There were people who had 2. There were people who had 1 risk factor. But some people failed with no risk factors. So these are not perfect predictors. But certainly if somebody does have risk factors, you should be especially careful. Now, in real-world studies, we also have some evidence comparing 2 versus 3 drugs, and this is a study by Paul Sachs from the US TRIO cohort, where he looked at various 2-drug and 3-drug regimens and found about a 2.2-fold higher risk of virologic failure with the 2 drugs than 3. However, remember, this is kind of a heterogeneous mixture of different regimens, so it's not a comparison of 2 specific regimens. So somewhat more specifically is recent data from Maggiolo in Italy, who did 2 different studies, and I'm putting them on the same slide. You're not supposed to do that, but it's the same author, the same patient population, the same study design. So with the caveat that this is not a single study, I'm going to do it this way anyway. And basically, he took people who were either starting or switching to BF-TAF, or people who were starting or switching to dolutegravir 3-TC. The characteristics of the 2 patient populations was very similar. Adherence was generally very high, but he wanted to look at what happens in those people who have low adherence. So on the left, you're looking at BF-TAF, and you can see a very high adherence. When you get down to below 70% adherence, you see a little bit of a drop-off in efficacy, and then when you get down below 60% adherence, there's a very big drop-off in efficacy. Dolutegravir 3-TC did very well down to adherence levels of 90%, but when you got below 90%, you saw a pretty deep, big drop-off, and below 80%, you saw virtually no effect. So this would suggest that there's maybe more forgiveness of poor adherence with BF-TAF than with dolutegravir 3-TC, and when I ask our virologists at Gilead why that might be, they point to the longer half-life and the longer dissociation half-life of bictegravir, and say that maybe it just has to do with the fact that you can get away with more missed doses than you can with the shorter half-life drug. But that's their speculation. And then this is a retrospective study, again from Italy, looking at 3 drugs versus 2 when you have mutations. So if you look at 3 drugs with no mutations, that's your reference point. If you have 3 drugs and you have a 184V, there's no significant drop-off in efficacy. But if you have 2 drugs with 184V, then at 6 months you see over 7-fold increased risk of failure, and at 24 months over a 9-fold increased risk of failure. This study would suggest that when you're on a 2-drug regimen, having 184V matters more than if you're on a 3-drug regimen. And that is, again, probably because, although we don't want our patients to have 184V, at least if they do have it and they're on a tenofovir-based regimen, there's increased activity of the tenofovir. Whereas if you're not on a tenofovir-based regimen, it's all bad news and no good news. We looked in a pooled analysis of a number of our switch studies where people were suppressed and switched to BF-TAF. In those studies, we found that about 10% of people had 184V or I, mostly V, and often had it with multiple other mutations, including other nucleoside mutations. And we wanted to know, did that affect the outcome of the study? Here are the results. So the pooled overall data is on the left, and then you see the various patterns of 184V plus or minus other mutations, but you can see it didn't matter. In terms of a last observation carried forward analysis, the results were the same with or without mutations. Keep in mind these are suppressed patients. So this is what all the guidelines say. If you have resistance mutations, and specifically nucleoside mutations, they pretty much all say the same thing. Use 2 nucleosides, one of them either being TAF or TDF, and use a high barrier 3rd drug, dolutegravir, bictegravir, or a boosted PI. Avoid dual therapy because you need the tenofovir to help compensate for the fact that you have nucleoside resistance. And I think this is good advice that all the guidelines agree on. Now I want to talk about blips, and that will lead me to talk about low-level viremia. So in our studies, our naive studies, we looked at blips. One of the things that had happened after BF-TAF got approved is that people said, well, I'm seeing lots of blips when I switch. Well, it turned out that people have said that about every new drug regimen that comes along. And there may be, one of the reasons maybe they're drawing blood more frequently with new drugs, or they're just kind of more aware and they're watching for it because it's a new drug. We found that the rate of blips was very low. At any one study visit, 1.3% of participants would have a blip. But we've also shown in other studies that if you take a single vial of blood and send it to 5 different labs, or even if you test it 5 times in the same lab, you can have a blip in one sample and no blips in the other 4. So there's a lot of lab variation that can occur with blips. We had a few people who experienced multiple blips, and more people if you looked at really low-level blips, down below 50, which most of us don't care about. Then we looked at the impact of blips on suppression. So on the left, you see that if your blips were below 200, it didn't make any difference in terms of your likelihood of remaining suppressed. It was the same as if you had no blips. However, if you were above 200, there was an increased risk of failure, but having a blip above 200 was associated with poor adherence. And this is a recurring theme that we see in a lot of both blip studies and low-level viremia studies, is that below 200 generally seems pretty safe and maybe completely unrelated to adherence, but as you get above 200, you've got a mixture of people, some of whom are very adherent and just happen to have these blips, others who are not adherent and are at risk for failure. And then we also compared the regimens. So we looked at BF-TAF, no difference, with or without blips in 1489 and in 1490, but interestingly, in the dolutegravir arms of those studies, there was an increased risk of failure with blips for reasons I can't really explain. This is my last slide, and then I'm going to just kind of talk without slides about low-level viremia if I have time. This was a study on from the EACTS conference from Spain, where they took people who had low-level viremia, defined as 50 to 500, who were switching to BF-TAF, and it's hard to know what to make of it. There was a modest increase in CD4 cell count, a modest increase in CD4-CD8 ratio, maybe a little better viral suppression. This is hard, though, because you're mixing people who are in that less than 200 category and the people who are above 200. So this may be a mixture of people who just aren't taking their pills and people who are truly having low-level viremia despite adherence. So if people do better, it's hard to know which group did better. So now I want to talk about low-level viremia a little more, because it's still a confusing issue, and I don't have great slides on it because a lot of the data is very, very old. We've known now for decades that some people have low-level viremia, and when you add an entirely new drug or you switch their drugs, it generally makes no difference. So I remember many patients who had low-level viremia on a tripla. Raltegravir came out, and I added raltegravir. It made absolutely no difference in their viremia. Now, if that viremia was due to replicating virus, the addition of a new agent should have shut it off. The fact that it did not, and this has been seen in multiple trials too, suggests that it wasn't replicating. And people like Bob Solicano have postulated that a lot of people with blips and low-level viremia are just releasing non-replicating virus from their latent reservoir. Some people's reservoirs may be bigger than others, and that's why we don't seem to be able to respond to low-level viremia and reduce it. That being said, there are some studies, such as a recent publication from the Swiss cohort, suggesting that even low-level viremia can increase the risk of failure. The problem I have with the Swiss cohort study is that one of causal attribution. So they looked at people with viral loads above 200. But think about the fact that if somebody develops a viral load of 180, some of those people are in the process of failing. Their adherence is poor, they're about to fail, and they start out with a low-level virus that's going to go up. Other people are just going to have that low-level viremia maybe for the rest of their lives. But if you don't account for that, you'll look at everybody who ultimately failed, find that at one point they had low-level viremia, and maybe mistakenly conclude that that was the cause of their failure, when in fact it was just the onset of their failure. I hope that makes sense. So it's confusing. Now, the other part about low-level viremia, beyond the replication aspect, is the inflammation aspect. And regardless of whether it's replicating virus or not, there is some evidence that people with low-level viremia may have certain higher inflammatory markers than people without low-level viremia, and this could ultimately lead to greater morbidity many years later. This is also a controversial point. The problem is we don't know what you would do about it. As I said, changing therapy has rarely been shown to work. Intensifying therapy has rarely been shown to work. And so there's very little that you can offer the patient outside of a clinical study, if it exists, to address low-level viremia. And my approach has been, one, talk about adherence, make sure they're taking their drugs. Two, if they're on integrase inhibitors, make sure they're taking it with the appropriate dosing separation for things like calcium and iron supplements and antacids. Three, if you have access to proviral DNA genotype, order one. It's going to probably show no resistance, and that helps you reassure the patient. And then four, reassure the patient. But of course, to establish that someone has this sort of benign form of low-level viremia, you have to have a period of time to monitor them. You can't tell them that the first time they have a viral load. It might be a year or two before you can say, don't worry, this looks like you're just one of those people who happens to have this, and it's nothing to worry about. So it's a challenge, I think, for clinicians and for patients to deal with this. I wish we had better answers, but there are certainly lots of research is being done to address this question. So I want to thank you all again for your attention, and I'm happy to take questions. Feel free to ask them in Spanish, and if I don't understand, I can always get help. Thank you.
Thank you so much, Dr. Gallant, for your brilliant, excellent presentation. Do you have questions for Doctor? Okay, please use the microphone. Use the microphone. Oh, somebody's coming to help you out. Can you hear me? Yes. Buenos días, doctor.
A remarkable speech. I would like to ask, is there any difference when you talk about low-level viremia? Is there any difference in the level of inflammatory biomarkers between non-replicant virus and replicant?
That's a great question. I don't know the answer, but my guess is we don't know that, because figuring out how much what virus is replicating and what is not an easy task. Nothing you can do in a clinical lab. It's a very time-consuming, tedious process done in research labs. And those research labs, to my knowledge, are generally not also looking at inflammatory markers, but it would be a great thing to look at. And I will bring that back to our leaders too to talk about, because that would be very, very useful to know that.
Yeah, thanks.
Somebody else? A question to Dr. Gallant?
¿Tiene alguna otra pregunta?
Somebody else a question for Dr. Gallant? Doctor, we know as guidelines state, we know to review the adherence of the patient and the figures that you already share, less than 5 copies, and there is no risk. But how long, based on your experience, do you recommend? How long do we need to wait after having all this list of adherence, interactions with other drugs, will keep this patient before a switch as first scheme for treatment? Bueno, en términos generales,
Means low-level viremia, the more relaxed you can be. Because, when somebody first shows low-level viremia, you don't know. Are they beginning to fail? You have no way of knowing that, because the only way you can know that is to predict what their next viral load will be, and you don't know what that will be. So in the beginning, you have no choice but to be a little concerned and to ask those questions, and maybe to do a proviral DNA. But if that pattern persists, and a year later it's the same, that's probably telling you that nothing bad is happening, because if they were failing, they would have failed by now. And if they were non-adherent, they would have failed by now. So unfortunately, you can't know right away whether you can be calm about this, and you may have to monitor them a little more frequently in the beginning to establish that there's a pattern. Now, in the old days, I used to routinely add a new drug, just as an experiment. So if I had somebody on a tripla, I would add a protease inhibitor. When raltegravir came out, I would add that. And I would see what happened. It almost never made any difference, so then I would stop that drug. It was an experiment, and I would promise them, this is temporary. If it doesn't work, we'll stop it. But give it a few months. There's no point in leaving those drugs on if they're not doing anything. Now we have so much data to say that this is probably not necessary, that if I were seeing patients today, I'm not sure that I would do that again. But it made sense back then as sort of an experiment on a single patient. But as I say, it almost never worked. So I don't think that switching therapy is the right answer unless there is a problem with the specific regimen. Is it a problem with drug interactions that could be lowering drug levels? Is it a problem with toxicity that they miss doses because they don't like a certain drug? You always want to ask that. Is there a part of this regimen you really don't like, or something about it you don't like? Then switching is quite appropriate. But just to switch a regimen that they're satisfied with because they have a low-level viral load probably is not warranted.
Muy bien. ¿Alguien más? ¿Alguna pregunta?
Somebody else, a question from the audience? Yes. You'll have the microphone. Good morning, doctor. Thank you so much for your presentation. This is a topic that we are really interested in, especially in what has to do the switch decision when to do a switching of treatment when there are low-level viremia and persistently. But my question is more towards, based on your experience, the prevalence of low-level viremia in regards to pharmacological interventions. Because we have patients with other comorbidity, they have antidepressants and anti-diabetics. And which is your experience that it might be based on a pharmacological intervention from the pharmacodynamics point of view? Entonces, estás hablando de
Low-level viremia, drug interactions with other medications that they're taking. Yeah. Well, it used to be a big problem when we were using a lot of boosted protease inhibitors and then later boosted L-bictegravir, where we had lots of drug interactions. In most cases, those drug interactions tended to affect not the antiviral, but the other drugs. Luckily, this is not nearly as much of a problem today because our newer drugs have far fewer interactions. But the one I can't emphasize enough is the chelation issue with integrase inhibitors. So this applies to all integrase inhibitors, and unfortunately, it applies to over-the-counter medications. Medications they may not tell you that they're taking. They may forget what you told them on day one about interactions. So we have to always remind our patients about calcium supplements, iron supplements, and over-the-counter antacids, and whether or not, if they're taking those, they're using the appropriate dosing with those. Because, yeah, you may tell them that the day you prescribe the medicine, but that may be 2 days after they learned they had HIV. They're not processing all the things you're telling them, and they're going to forget that. And when then somebody has a stomach ache, they're going to get told, here, take this antacid, or they decide they want to take a multivitamin that has calcium and iron in it, and they're going to forget about that interaction. And we know that that will lower integrase levels. So that is the one thing I would always talk to patients about, even the ones who have suppression. Just remind them every once in a while, make sure that they're not taking those kind of things. But other than that, there are no over-the-counter medications we have to worry about. We do have to worry about some things like, rifampicin and some of the older anticonvulsants, but we would know if they were on those. So that we shouldn't be making mistakes like that. But I do worry more about the cations.
Okay, thank you very much.
Bien.
Is there any other question for Dr. Gallant? We still have some time. Okay. Thank you so much, Doctor, for your presentation, for being with us on this Congress. Thank you so much. And I give you this document. This is an acknowledgement of your presentation. We have time. We are doing well for time for next speaker. Let's just wait a little bit because Doctor is going to be bio streaming. And please don't leave this place. We will be starting in short, okay?
muchas gracias a todos por la espera y dando continuidad.
Continuing with this agenda, now we will be talking about this important, very important, relevant topic in regards to the follow-up and treatment and what it takes, the care we should have for our HIV patients. And the topic that we will be listening is the approach of the 5 M's on the care of HIV geriatric patients, elderly patients. So for this matter, we have, well, the topic is by Christine Erlandson. She is from the University of Denver, Colorado, the USA. She is an associate professor on infectious diseases with a secondary appointment of geriatric medicine of the medical campus Anschutz from Colorado University, Denver. As of 1919, she has been in charge of this the workshop that there was taking place at Johns Hopkins University. She was talking about all these mechanisms of aging and all the factors that inflammatory, dysregulated factors and HIV might bring about some early aging of these people. So she's participating on trials for prevention of the physical deterioration, exercise, statins for HIV, and important studies for as observer. Doctor, because of agenda, could not be attending in person, but we have tape she recorded previously, and she will be connecting later, and she logging in, and she will be able to answer questions. Buenos días, muchas gracias por esta oportunidad.
My name is Christine Erlandson. I'm at the University of Colorado in Denver, Colorado, and I'm going to talk today about a framework for approaching aging and HIV. So we're going to begin by reviewing some epidemiology of aging conditions among people with HIV, and then I'll talk about how we might use the 6 M's or the 5 M's to provide a framework for how we think about care in older individuals with HIV. I'm sure you're all very familiar with this timeline of how HIV has changed over the past 40 years, but I think it's important to go back and remind ourselves that we have now had effective antiretroviral therapy for over 25 years, and more recently, our guidelines support care, or support that we provide that care to all people with HIV, regardless of their CD4 count. As a result of these improvements in treatment and access to effective care, we've really seen a tremendous transition in the epidemic of people with HIV. In the United States, we see that people aged 50 and older now reflect about half of those with HIV. The majority of these increases reflect that people that acquired HIV at younger ages are now aging successfully and have grown to be older. However, we do, of course, continue to see new diagnoses in older individuals. And the proportion of people living with HIV that is over age 50 years of age is estimated to reach about 75% by 2030. We see similar trends globally with a steadily increasing rate of people aging with HIV, regardless of the region of the world that we look at. Although these proportions may be less than that we see in Europe and North America, and as seen in the blue line, the sheer numbers of older adults is probably much larger in many of these other regions, in particular sub-Saharan Africa. And you can see the increase in Latin America and Caribbean in this gray line at the bottom, just below the US and North America here. As you can see in the top half of this figure, the life expectancy of people living with HIV in the triangles has continued to improve over the last 2 decades and now nears that of people living without HIV, as shown in the circles at the top. In the bottom half of the figure, we see the expected time before experiencing a comorbidity. A 21-year-old with HIV, for example, is expected to develop at least one additional comorbidity within about 10 years. And this is in fairly stark contrast to someone without HIV who may have another 28 years or so before they develop comorbidities. And unfortunately, this bottom curve really hasn't changed that much over the last 20 years. As people with HIV develop comorbidities at younger ages, it isn't surprising that the comorbidity burden is particularly high as age increases further. The figures on the left side of this slide show the proportion of people with HIV with comorbid conditions on the top and controls on the bottom. The yellow color shows those with no comorbidities besides HIV, which is notably lower across all of the age groups in those with HIV compared to controls. The figure on the right shows more recent data among just women, and those with HIV on the right, those with HIV on the right side of each set of bars, and the women without HIV on the left side. A similarly higher comorbid burden is seen among women with HIV across all of these different age groups. With the increasing proportions of older adults living with HIV, this comorbid burden is only expected to continue to increase, as you can see by this figure, highlighting the expected projections of comorbidities by the year 2030, with the increasing proportion of older adults experiencing 3 or more comorbidities as seen in that yellow color. So why do we see this higher burden of comorbidities? Well, numerous factors probably contribute. From more basic cellular factors such as immune senescence, mitochondrial damage, and epigenetics, to HIV-specific mechanisms such as antiretroviral therapy, toxicity, issues with the ongoing viral replication in the reservoir, and disruptions in the microbiome or gut integrity. Lastly, people with HIV may experience a greater burden of stress or mood disorders, prior trauma, greater socioeconomic barriers, and lifestyle factors such as poor diet or low levels of physical activity likely also contribute and appear to be more common among people with HIV. Are there certain comorbidities that occur more commonly in people with HIV? Well, this seems to vary quite a bit on the population that we look at. This table shows recent data from 2 US-based cohorts, the MAX, or Multicenter AIDS Cohort Study, and WICE, or Women's Interagency HIV Study cohorts, between the 2018 and 2019 visits, when these people are seen for study visits. Among about 4,000 participants who are well matched on similar risk factors for acquiring HIV, you can see that some more comorbidities were strikingly more common among people with HIV, as highlighted in the bold, such as diabetes, metabolic syndrome, chronic kidney disease, liver disease, and depression. This increase in metabolic risk factors in particular may put people with HIV at a much higher rate of cardiovascular disease, and this distribution of comorbidities between people with and without HIV may also vary by geographic setting. The other question we ask is what comorbidities are just more common in general versus which comorbidities do we expect probably increase drastically as age increases? Well, this is data from another US cohort called the HOPS, and it's an observational cohort that's been following participants for many years. You can see that some conditions, such as psychiatric disease, in the blue line, are present in about 50% of people, regardless of their age. Other conditions, such as cardiovascular disease and dyslipidemia, shown in the red and green lines, increase drastically as age increases. And as we learn more about aging in international settings, we will likely see very different curves for many of these comorbidities than we see in the US. Another important question is whether these conditions are more common in people with HIV or whether they occur earlier in people with HIV. And this is an important distinction that can inform our screening and our prevention. In the figure on the left, you can see an example of a condition that is accentuated, or it occurs more commonly. It peaks at about the same age and follows a similar curve. In contrast, in the figure on the right, you can see a condition that is both accelerated and accentuated. It occurs earlier and it occurs more commonly. If something occurs more commonly, we need to emphasize screening and prevention, whereas if something is occurring earlier, then we may change our treatment and screening guidelines from that we may follow in the general population. A couple examples: cardiovascular disease appears to occur at an earlier age among people with HIV. We screen cardiovascular disease risk factors yearly in people with HIV regardless of age, and based on some of our findings from the recent REPRIEVE study, we may end up starting statin therapy at much younger ages among people with HIV, really regardless of their cardiovascular disease risk factors. Similarly, osteoporosis occurs at younger ages in people with HIV, particularly those who have had extended exposures to TDF or tenofovir. And the HIV primary care guidelines reflect this and recommend screening at least 15 years younger for men than what's recommended in the general population. Other conditions, such as anal cancer or cervical cancer, appear to just occur more commonly or accentuated, and our screening is more frequent, or something that might not be done at all in the general population. So many different guidelines exist to try to help guide our screening and our treatment for older adults, some of which are listed here and vary across different geographic settings. Few are comprehensive enough to really address both general aging issues and unique issues for people aging with HIV, and may require consulting multiple different guidelines and things that we honestly don't have time to necessarily do in clinic. This can lead to frustration, way too much to accomplish in a short clinic visit, both for frustration at the level of the provider as well as the patient. So how do we help prioritize this long list of recommendations? Well, the geriatric world uses an approach that they call the 5 M's to help keep a visit focused upon 5 key factors: mind, mobility, medications, multi-complexity, and what matters most to the patient. We've proposed adding a modifiable principle, particularly for our older patients that fall into these younger age ranges, where we think of modifiable risk factors that may have a particularly long-term impact and be preferable to more medications or interventions. I'm going to touch briefly on these components to help provide some examples of how these M's highlight the key issues in HIV and aging, and may offer some frameworks for how we think about conducting clinic visits in older adults. So the modifiable component is probably what we're all most familiar with in the HIV clinic: updating immunizations, substance use screenings. In an older adult population, we can also begin to expand this to look at things like nutrition. Are people getting enough food? Do they get enough protein in their meals? Are they physically active, getting out of their home and meeting with other people? Are patients safe to drive if they have a car and use that for transportation? Have they had recent vision or hearing checks to ensure they can actually see road signs and pedestrians that they may encounter on the road? Many of these screenings can be done by self-report before someone checks in, or could be done by a medical assistant at check-in, or even embedded somewhat into the medical record system. Number 2 is multi-complexity or multi-morbidity. And this concept of multi-complexity or multi-morbidity reflects that many of our patients have multiple different conditions that occur at the same time. Treatment for one condition may actually worsen another condition or directly conflict with treatment for another condition. For example, giving someone clopidogrel and aspirin for cardiovascular disease may worsen their peptic ulcer disease. Their beta blocker that they're on for heart rate or blood pressure control may worsen their fatigue, and their diuretic to help treat some fluid overload may worsen their prostate condition symptoms and cause them to be up many times during the night to urinate, therefore worsening their fatigue. So prioritizing the most essential treatments with the least complexity and including things such as non-pharmacologic options may be associated with both greater adherence and greater improvement in symptoms as people are getting older. And sometimes the adage, less is more, is an important factor here. An example shown in an HIV clinic in New York City. In this figure on the right, among nearly 3,000 patients with a mean age of 52, comorbidity occurred in 75% of those that were less than 50. All participants by the age of 75 or greater had comorbidity, and multimorbidity in nearly all of those, as shown by that orange bar. The majority of these comorbidities were thought to be high risk or associated with a high risk of mortality, or they were thought to have an impact on function, such as walking speed, as shown in that yellow bar. So are we able to use interventions that might treat or prevent multiple different comorbidities, such as improved physical activity, improved diet, or maintaining healthy weight? Physical activity is an example, as numerous benefits of physical activity are seen both in the immediate setting and in the long-term setting, as seen in the figure on the right. potential of growing interest in the gerontologic world is this concept of therapeutics or xenotherapeutics, or interventions that target multiple different pathways that are impacted by aging, such as a therapy that could change mitochondrial function, decrease inflammation, improve metabolic factors, and target multiple different endpoints to improve the overall aging process. Some of these agents might include things like metformin, dasatinib, and quercetin, but many of these are still under investigation both for safety and for long-term efficacy, and are not currently used for xenotherapeutic effect in routine clinical practice at this point. Physical activity, on the other hand, is very well established as a multi-morbid intervention that can treat or at least help prevent multiple different comorbidities. And this is my primary research interest, and in many of our studies, we found that patients report that they're never asked about physical activity or given specific advice about what they should do to exercise. The Centers for Disease Control and the World Health Organization recommend including not just cardiovascular or aerobic exercise, but also regular inclusion of strength exercise and balance exercises or flexibility exercises, particularly for older adults. One of the potential benefits of the COVID pandemic was actually access to numerous different free or low-cost exercise interventions. There's many different YouTube videos that are available, such as short yoga workouts for older adults that are available from Silver Sneakers that patients can find online. Many of these are simple. They just include a chair, not a lot of equipment required. People can make their own weights or use water bottles or other household items for strength training. So cost shouldn't be a barrier to exercise, but I think sometimes that simple instruction of what should I do, how often, and for how long may be a bit of a hindrance for some of our patients in actually starting their physical activity regimen. Number 3 is the mind. Most specific to HIV is HIV-associated neurocognitive disorders, where we may see things such as impairments in concentration, memory, planning, and organization. Although the risk of Alzheimer's disease doesn't appear to be specifically increased in the context of HIV, certainly as the population increases in age, we will see an increasing incidence in Alzheimer's dementia just associated with age. And also relevant in this category of mind is the added burden of mood disorders that we do see very commonly among people with HIV, regardless of age. These can both complicate the treatment of and the diagnosis of dementias and other comorbidities. And many of the treatments that we use for mood disorders are also high risk in older adults. They can worsen their falls risk, their mobility impairments, and we see a lot of drug interactions with many of these treatments for mind, thus complicating this category. At a recent meeting that we hosted last month, the International HIV and Aging Workshop, we actually had a session debating whether we should or should not be screening for cognitive impairment in the HIV clinic. Knowing that many of these assessments take a long time, we don't always have treatment options for patients, but sometimes patients really just want to know if there is something wrong or if they need further evaluation. There wasn't a great consensus on whether people should screen or not, but I think we heard both sides of the story. An initial cognitive assessment can be brief. It doesn't have to be an extensive neuropsychologic testing. The MOCA probably takes about 10 minutes to complete, so it can be a little bit of a barrier in a busy clinic visit. One simple test that some of the geriatricians strongly recommend that really just takes a few minutes is the clock draw, just asking a patient to draw the face of a clock. A little bit more problems with this as we switch more from traditional clock faces to more of the digital clock faces, but I think we can learn a lot if we see a clock face that looks like that shown in the upper hand corner, and just maybe recognize more impairment than we had anticipated or expected. Mood can be assessed fairly quickly using a PHQ-2 or PHQ-9. Others may advocate for something called the Geriatric Depression Scale, which gets into a little bit more factors that may be unique to older adults, such as factors of loneliness or isolation. And then we also need to consider that many factors may contribute to cognition that we can treat or improve. So trying to rule out underlying factors that may be driving changes in cognition or mood, such as medication side effects. I mentioned beta blockers or other treatments. Hormone or vitamin deficiencies can be a factor, particularly in those that have poor or limited nutrition. There's increasing data that both hearing and vision impairment can worsen cognitive impairment due to changes in neuronal pathways. So quickly assessing someone's impairments that they might note with their hearing or with their vision may provide an outlet for something that we can actually treat and help to improve their current cognitive impairment, as well as trying to slow further progression. Importantly, we need to understand the impact of any cognitive impairment on day-to-day function. Is someone still safely able to prepare their food at home? Do they have access to meals? Can they manage their finances? Can they manage their medications, or could they use extra assistance with this? High adherence to antiretroviral therapy can help prevent any additive effects or any additive problems, and is important important to continue current antiretroviral therapy. There's no current recommendations to changing regimens based on the level of penetration of antiretrovirals into the central nervous system, although we do know that there's certainly cognitive factors associated with efavirenz, and that's probably best to avoid if possible. In the recent studies from the AIDS Clinical Trials Group testing the concept of ART intensification to improve cognitive function with the additive therapy of Maraviroc or other therapies have not shown much of a benefit and is not currently recommended. Physical activity and mental stimulation throughout the lifespan are really important factors in trying to maintain good cognitive function and prevent those declines with later age, as is social interaction and meaningful engagement with other individuals in the community. The next one is medications. And while some medications are clearly life-sustaining, there's a debate on how much benefit patients may experience when their medication burden becomes truly excessive. In the general literature, 5 or more medications is considered polypharmacy, and many of our patients quickly reach this when we consider that oftentimes they're on 3 or more medications for their antiretroviral therapy alone. In fact, in one clinic of older adults in the San Francisco area, the average number of medications was 14, and 35% of patients were taking 16 or more medications. With this many medications, adherence decreases, side effects increase, cost increases, drug interactions increase, and some studies have actually shown that mortality is higher even after accounting for the comorbidities that lead to those additional medications. I'm sure many of you are familiar with this and already use this helpful website from HIV Drug Interactions, but just a reminder, this is a really fantastic resource when we're considering potential drug interactions, both within HIV medication classes as well as with non-HIV medications. Boosting agents such as ritonavir and cobicistat can be particularly problematic in older adults, especially when they need things like a corticosteroid injection that their orthopedic surgeon or their other provider may not consider an important new medication. We really need to empower our patients to be their own advocate, and anytime they have a new medication started, regardless of the route of administration, to check with the pharmacist or check with you as their HIV provider. And lastly, many medications don't necessarily need to be continued throughout the lifespan. Certainly, medications have a period of time in which we expect them to have a benefit. If someone is on hospice, there's probably not a lot of ongoing benefit of their statin therapy, whereas we could have a 95-year-old that we expect still has a great life expectancy, and it's completely appropriate to continue that statin. So just thinking of the benefits of statins, or benefits of different therapies and harms in terms to the expected long-term benefits of these medications. Similarly, some treatments may not be required anymore. Symptoms may have improved. Many people get started on proton pump inhibitors for reflux symptoms, and perhaps their reflux gets better over time. And just giving trials of periods of times where we can stop a treatment and see if the symptoms return, or if we're able to stop these medications. Polypharmacy can be exceedingly difficult to stop. Many patients don't want to stop their medications. They feel that they've had benefits of these medications. They may recognize more of the benefits instead of the harms. And the Canadian D-Prescribing Network has really put together some great resources. They have a website that has lots of pamphlets that you can provide with patients on harms of medications. It helps patients identify maybe when they're not having benefits from some of their medications. There's algorithms algorithms for providers on how to decrease certain medications such as benzodiazepines and how quickly can you taper down. And then they even have made a concerted effort to increase translated materials. Here's just an example of a tapering down to get off a tranquilizer or a benzodiazepine medication and how you slowly taper that medication over a period of time to decrease any withdrawal effects. So this is a great resource if you're looking for ways to help try to decrease medications that maybe aren't having a benefit anymore. And the next M is mobility, and this is encompassing many different factors, but one key component is how someone moves around. This can be measured with simple tests such as a 4-meter gait speed or just the regular walking speed across a short period of time or a short distance, or something like the ability to rise up from a chair. This is a seminal study that was published several years ago, but it demonstrates the strong association between slower gait speed and survival across different ages. Just for an example, a 70-year-old with a gait speed of 1.6 meters per second, so a fairly brisk pace, is expected to live another 30 years, as you can see by this graph. And if we compare that and contrast that to someone who has a very slow gait speed of 1.2 meters per second, we expect that they probably only have about 10 years of life left. So just how this simple measure of gait speed can provide something so predictive in terms of life expectancy. From data in populations both with and without HIV, we know that physical function impairments are also a major predictor for loss of independent living. We've shown that frailty and physical function impairments are associated with falls and fractures, as well as an increased risk of some comorbidities such as cardiovascular disease and diabetes. Mobility also encompasses things like balance, and we know that many of these functional impairments tend to be, functional outcomes tend to be even more impaired to people with HIV who may have exposure to older antiretroviral therapies that may impact their ability to balance or cause neuropathy. And here you can see just an example of something that's simple as gait speed and how this may differ in people with and without HIV. The bottom red line shows those with HIV, and the blue line shows those without HIV. And you can see a faster decline in gait speed among men with compared to those without HIV with increasing age. The figure on the right shows a consequence of that slow gait speed and neuropathy, which is an increased risk of falls. And we see, in comparison to a typical fall rate of about 30% per year for people age 65 or older in the general population, we see similar or higher rates in many of these different cohorts of people with HIV where the mean age is closer to 50 or 55. So very high rate of falls among people with HIV that we can both screen for as well as help prevent. With this high rate of osteoporosis that we see among people with HIV, up to a 4-fold increased higher risk of osteoporosis than we expect compared to people without HIV, and this high rate of falls, we worry a lot about the risk for fractures. And as shown here in a large database in the Boston area in the bottom two figures, people with HIV have a markedly higher rate of fractures beginning at about age 40, both among women in the figure on the left, as well as among men in the figure on the right. Frailty is a closely related concept that you might hear about in the context of HIV and aging, and frailty is more of this concept of vulnerability that we might see, that as someone encounters a stressor, they may be continuing along at a usual state of function, they encounter a stressor such as a hospitalization or an illness, and they have an acute decline in their function. Over time, they may be able to bounce back and slowly improve, but then they never quite get back to their prior level of function. They encounter another stressor and have a continued decline. And just this slow decline that we see over time, people have that inability to bounce back after stressors. We see frailty defined a couple of different ways, most commonly, that being the Fried frailty phenotype, or this concept of the accumulation of the more things that are wrong, the more likely that someone's frail, and this accumulation of deficit or frailty index that's often defined by Ken Rockwood's group. The frailty phenotype, or Fried's frailty phenotype, reflects this vulnerability, and it's often measured through 5 different components, considering how quickly someone could walk, their weakness or level of strength, that they have low levels of physical activity, may have a lot of fatigue and some weight loss. And that freed frailty phenotype is primarily done in the research setting at this point among people with HIV, as it probably takes about 10 minutes to assess and isn't necessarily feasible in a routine clinic visit. The frailty index, on the other hand, just looks at the number of variables that one would expect, or the number of variables that are impaired, and divides that over the number of variables that are assessed. And these are typically defined with variables that increase in age and are associated with health status, but aren't ubiquitous with age. So we wouldn't necessarily look at age itself as a variable, but more things like, does someone develop osteoporosis? Do they develop hearing impairments? These can be derived from chart review and calculated in advance of visits, but it does take some initial time to set this up. So how do we assess mobility in the clinic? Or are these tests that we might actually be able to do in a routine clinic visit? Well, it can be something as simple as measuring a gait speed. You could actually just watch a patient walk to their room. Are they able to get from the front desk where they check into clinic back to their room in a fairly brisk manner? Are they struggling to walk that short distance? So it can just be informal observation. Some clinics have actually used walk plates that you can use on the ground, and just the patient walking over it will trigger the timing. Those are obviously a bit more costly and require a bit more time for setup, but it's a simple measure. We can look at how fast a patient can rise up from a chair, or are they actually able to get up from a chair without using their arms. The short physical performance battery is a more standardized assessment that looks at how quickly someone can stand up 5 times, but just standing up once can also be a decent measure of someone's function and ability to get up and down from a chair, get up and down stairs. We can do a timed up and go, which involves this person in the lower right, where they stand up from a chair, walk a short distance, turn around a cone, and walk back to the chair. And it's really mimicking daily activities someone could have in life. And then lastly, we can just ask, do you have limitations in your daily activity? Have you fallen in the last few months? Do you have a fear of falling? And these can be important initial clues that something may be declining in someone's mobility, and we can intervene earlier rather than waiting for further and faster declines. Frailty, as I mentioned, can be a little bit more challenging to assess in a routine clinic visit. The clinical frailty scale is almost an eyeball test, or something where we can just look at a patient and understand how well they might be. And it grades individuals from a score of 1 to 9. Takes about a minute to kind of think through this and assess. Is someone robust? They're active? Do they exercise regularly? They're among the most fit members in their group? They have a 1. Someone that's more vulnerable, they face a lot of challenges that slow them down, but they're not completely dependent, they might be a score of 4. This actually correlates fairly well with both the frailty index and the frailty phenotype, and really just takes a minute at the most to assess in a clinic visit. So how do we incorporate some of these mobility measures or measures of frailty and function into the clinic? Well, first, we can try to treat or manage frailty. If someone has frailty and has had a lot of weight loss, we can have a nutritionist work with them, really concentrate on making sure they're getting enough protein in their diet. If someone needs a referral to physical therapy to help increase strength, or focus on de-prescribing some medications to potentially decrease fall risk. We might also use frailty to help prioritize patients that need advanced care planning, or might benefit most from a geriatric referral. A frail individual may benefit from visits every 1 to 2 months, while a non-frail patient with a few more comorbidities may only need to be seen every 6 to 12 months, so it may help us to determine the frequency of clinic visits. And frailty can also help to guide certain treatment decisions, such as the risk and benefit of certain preventive treatments. An untapped research area is whether frailty can inform antiretroviral therapy choices. Are there certain regimens that are safer or have better pharmacokinetic data in older frail patients? And including older adults and measures of physical function in our clinical treatment trials would kind of help us to think about how we might answer these questions moving forward. The final point, or number 6, is what matters most to the patient. And our visits should really focus on this question: what is most important to the patient? Both the big picture and even what's most important that day. What do you need to address that day? We can use existing tools to help gather some of this information. There's tools available such as patientprioritiescare.com that can inform treatment burden and acceptability. This can be reviewed with other case managers or other staff in the clinic and looked at ahead of time. Can help make sure that patients are adherent to their plan. If they have buy-in and they agree with their current treatment burden and current plan, then they're much more likely to be adherent. And it's also may be helpful in identifying medications for deprescribing. If a patient really identifies that they are overwhelmed and their priority is to try to get off medications, then maybe that can be the focus of the visit that day. And lastly, we need to think about considering the patient's health trajectory to inform screening and interventions. Is a patient really likely to have a benefit from continued cancer screening with the functional state that they're in, or might this procedure cause more harm? And in many patients, yes, they should absolutely have this procedure and they have a definite benefit from it. If they're young enough, or if they're more likely to die of another cause and they're 65 years old with terminal lung cancer, then their colon cancer screening probably isn't of benefit. Many of our patients have struggled with trauma, lived through the early AIDS epidemic, quit using methamphetamines and alcohol, and they may choose that they have zero desire to quit smoking as long as they understand the risk and benefit. As hard as it may be, we may need to respect what matters most to their quality of life and decide where we really need to push to move forward. These decisions can best be preserved at the end of life by having a trusted medical power of attorney and advance directive. And we've previously shown that less than 50% of middle-aged or older people in our clinic had a documented advance directive or care plan. And furthermore, less than 53% of people that died had actually completed an advance directive in advance. Many of our older patients did not anticipate living as long as they have. They've lost so many of their support networks and they may be disowned from their families. So helping them to designate a power of attorney or complete any legal paperwork in advance can really be key to ensure that their wishes are followed out in their end stages of life. So how in the world do we accomplish all of this in the HIV clinic? Well, we can engage other folks in the clinic. We can ask our social workers, our nurses, our medical assistants, our pharmacists to help with different aspects of this. In the US, we can bill insurance for wellness visits on a regular basis or on an annual basis. So those can be options of ways to kind of have one visit a year where we cover longer issues and then shorter visits in between. We've been working with a geriatrician in our healthcare system to establish a geriatric shared clinic option where certain patients might be referred to the geriatrician for a more detailed assessment. If the patients deem to be much more complicated, they may follow with that geriatrician, or the geriatrician may just offer some consultation and some suggestions back to the primary care. There's certain organizations such as the American Academy of HIV Medicine that hosts courses or different training opportunities such as the intensive course in HIV and aging, where HIV providers can gain additional training in geriatrics. And then, as I mentioned, some clinics have established this geriatrician model where there's geriatric care embedded within the HIV clinic. I think from a long-term standpoint, this is probably a more difficult solution in that we have both a shortage of geriatricians and HIV providers. However, it really establishes a great infrastructure and makes the care cascade easier for patients. I wanted to share an example of a project that some folks that we've been working on in Colorado have been involved with. The Health Resources and Services Administration, or HRSA, awarded several demonstration awards a few years ago to help establish geriatric care or HIV and aging care in the community settings. And the Colorado Health Network, which is a community aid service organization in Colorado, submitted an application and has been working on establishing the iChange model. They focus this on the geriatric 5Ms and have a really detailed screening assessment where they go over many of these things that we talked about today. It's one long visit. They have about 80 to 90 minutes that they spend with the patient and go over many of these different factors from a case management standpoint. The physician is not, or the physician or the other provider is not involved in this component. And then they help to prioritize a care plan with patients. Do they need to get a referral to an ophthalmologist? Do they need to get a hearing assessment? What else do they need to follow through with their care plan? And I think this has been really successful. We'll see some more outcomes from many of these demonstration awards in the next few years. So in summary, as the population of older adults with HIV continues to grow, they will continue to face an increasing burden of comorbidities, many of which occur more commonly and in an earlier age in those with HIV compared to those without HIV. Our screenings and treatments may need to differ for these patients to ensure the most effective care, and the 6Ms framework can help to prioritize key components of care for older adults with HIV. The most feasible, efficient, and effective ways to implement the care for older adults with HIV, however, does need to be further studied, and there's still a lot of unanswered questions as to the best models for caring for these patients. I'd like to thank you for your time. I just wanted to put in a plug that CROI, the Conference on Retrovirus and Opportunistic Infections, will be held in Denver this year, so I encourage you to come and visit our fabulous city and see our medical campus. I'd like to thank our study participants, study team members, collaborators, mentors, and mentees who have provided a lot of the data for this work. Miley Karras is a collaborator who helped to co-conceptualize the 6Ms approach with me, and we've had a lot of fun kind of thinking about how to implement this. Jacob Wacker is our geriatrician in the HIV clinic who's provided a lot of input on the best models of these cares. And then the AIDS Clinical Trials Group and Max Weiss combined cohort studies have been great resources to look at things like falls, polypharmacy, and many of these complications in aging patients. They also have data and samples that are open for any investigator, and I'd be happy to talk with any of you on how to access those resources. So I thank you again for your time. I'm happy to answer any questions in the Q&A session, and enjoy the rest of your conference. Thank you so much.
La doctora Erlandson se conecta con nosotros desde su centro de trabajo. Por si alguien tiene alguna pregunta, esperemos verla en un momento en pantalla. Hi, Dr. Erlandson. Thank you very much for your time. Thank you very much for your generosity, and I hope you can come with us one day in person.
Thank you.
¿Alguien quiere hacer un...
Are there any? Yes, doctor, please go ahead.
Wait a minute, please.
Bueno, buenos días.
Good morning, doctor. My name is Yolanda Quintero. I am a nutritionist. It is an honor to hear your presentation. I loved it. And I have a concern. Nutrition-wise, we clearly have a very important role to play, all the way from these geriatric symptoms implementation that we see, presarcopenia, sarcopenia, frailty. We see it very frequently and more often. So nutrition-wise, we're always going to look for a way to optimize the protein input, maybe vitamin D, calcium. But I have a concern, which is about the use of nutritional supplements. From your experience and what you've had the opportunity to do, maybe you've also worked with nutritionists and dietists, the use and the effectiveness of nutritional supplements in these geriatric syndromes. Where does it become fundamental, or how much should we optimize the nutritional care? And supplements, talking about polymeric formulas, protein modules, all of that. I would like to know a little bit about your experience on it.
Support and maybe some compliments. You can share your experience with this topic in your clinic.
Yes. Unfortunately, we actually have a very difficult time accessing nutrition services within our clinic unless a patient has diabetes. And so my experience with being able to work directly with a nutritionist has been a bit limited. I think there is a lot of data on how important nutrition is in the geriatric population, both ensuring that a participant or a patient has enough calories, especially if they've lost weight, trying to ensure that they're keeping their weight stable. Protein, obviously, as a person mentioned, is also a very important part, and there are some recommendations on the amount of protein per kilogram of body weight to try to ensure our patients are getting, with the caveat that impairments in kidney function may change that a bit. I think many of our older adults probably don't get enough protein, and that may be one of the most important pieces for maintaining muscle mass in older adults. I think with vitamins and other supplements, we worry a little bit about the polypharmacy and adding more medications if there's not a clear benefit and a potential interaction with other medications. So I usually caution patients in terms of adding supplements unless there's a clear reason that they need it for a deficiency. And then I think that is a really excellent point, though, about how important nutrition is, particularly in our older adults, and asking about them, making sure they're getting enough calories.
Thank you. Doctor, is there any consideration with older women, specifically women?
In terms of nutrition or just in general?
General.
Yeah, I think we, at a couple of our conferences, have really heard more and more about how menopause is probably an underaddressed issue in older women. I'm very excited that the AIDS Clinical Trials Group is going to be sponsoring a hormone replacement study for women with HIV. I think a lot of providers have been a bit hesitant to prescribe estrogen replacement or other hormone replacement without a lot of safety data, especially in people with HIV who may have an increased risk for heart disease or other complications. So we will hopefully be enrolling for that study in the next few months, and then can have data in the next few years about the safety and efficacy of hormone replacement therapy for treating some of the symptoms of menopause. As I've heard more about in the last year or two through some of our HIV and aging conferences, just asking patients. A lot of times we forget to ask women if they're having menopause symptoms, if they're having hot flashes, and trying to help them address those symptoms. And then I think similar to the general population, cardiovascular disease is probably presents differently in women, and that may be even more true in women with HIV. So making sure we're optimizing cardiovascular risk factors in older women with HIV, as they may present with different types of symptoms for cardiovascular disease, or may have different risks and lose some of that protective effect of estrogen that we might see in the general population.
Okay. ¿Alguna otra pregunta del público?
Are there any other questions by the audience?
I have a question. Are cognitive impairment and frailty more associated with some specific class of antiretrovirals, or is it just a matter of aging? And a comment, I think the matter most is very compelling, and because not necessarily what matters most for the physician is the same that matters most for the patient. I think that was some insight to apply. Thank you very much.
Yes, thank you for your comment. We have primarily seen that efavirenz may have an impact on cognitive function, and we've seen a little bit of the same in the AIDS Clinical Trials Group in terms of efavirenz on other risk factors that may be associated with frailty. The integrase inhibitors, there is a little bit of data that we had published recently that potentially a concern for some cognitive impairment, although that has been a bit debatable and depends on the population we're looking at. In general, we haven't seen strong recommendations for changing antiretroviral therapy to penetrate more into the cerebral spinal fluid, but I think in anyone that has cognitive impairment, making sure that we've transitioned them off of efavirenz is probably the most important point, that we do have excellent, consistent data on the potential neurocognitive impact. We haven't seen as much data with frailty. I think part of that has been complicated by confounding with age and duration of antiretroviral therapy and how people have changed over time to different therapies. But certainly treatments that might impact neurocognitive impairment, we might also expect to impact frailty because those two geriatric syndromes are so closely related. So thank you for the question.
Yeah. ¿Alguna otra pregunta?
Are there any other questions?
Sorry.
Una pregunta.
Hi, can you?
Hola, doctora, buen día, ¿me escucha? Muy bien. ¿Qué nos puede decir del tratamiento farmacológico de pacientes con disfunción cognitiva severa y VIH? Yo creo que en cuanto a la terapia,
In the treatment of the dementia associated with HIV.
Yeah, I think that the most important thing for HIV-associated dementia is making sure that people have a suppressed viral load and starting therapy as soon as we can, trying to ensure consistent therapy. There isn't a specific recommendation for types of antiretroviral therapy that we may use in people with neurocognitive impairment. Unfortunately, there's not great data for how we would treat neurocognitive impairment in the general population, other than minimizing risk factors and trying to ensure cognitive stimulation, decrease other risk factors that may contribute to cognitive impairment like depression or other comorbidities. Physical activity probably has some protective effect, as well as potentially nutrition in terms of Mediterranean diet or anti-inflammatory type diets. But in terms of specific recommendations for treatment with for neurocognitive impairment for people with HIV, I don't think we have a whole lot of treatments right now. Just to put another plug in for a study that will be starting in the AIDS clinical trials group, there is a study that's going to be looking at some cognitive treatments or some different antidepressants for neurocognitive disorder. So we'll hopefully, again, have some more information on those in the next couple of years. But right now, unfortunately, not a lot of great treatment options.
Okay, thank you.
Well, thank you very much again, and le damos un aplauso a la doctora.
Please a big round of applause for Dr. Erlandson.
Have a good day, doctor. Bye.
Thank you.
Bien, seguimos. El siguiente espacio es para un receso.
So now we are going to have a break. Please, let's be back at 12, please, at noon. Thank you.
ven? Sí, sí, gracias. Sí. Sí. Es que no sabíamos cómo iba a estar. Que no se conecta. Sí, ¿cuánto dura exactamente el tiempo? Ok, por si empezamos a las 12, sí. Todos nos estaríamos en tiempo. Sale, gracias. Sí, no. Buenas tardes. Vamos a dar.
Let's start with the last part of this program. For that matter, we are going to introduce virtually on video streaming a lecture from Letze de la Torre, Letze de la Torre doctor. She is the head, as of 2019, General Director, CEO of SENSIDA. She is a surgeon and she was at the National University, Mexican University, on infectologist and internal medicine at the National Institute of Health and Sciences of Salvador Subirán. She has a public health master's in developing countries at London, and also she has had experience and clinical research. So without a further ado, I would like to introduce Dr. De La Torre from Sencida. She says, good afternoon. Thank you very much for this invitation to the Congress. And in the next minutes, we will be tackling a very relevant topic, which is the combined prevention of Mexico, which is the current status, and the views into the future. One of the core elements for infection control should be focused on prevention. Global-wise, there is a coalition known, Global Coalition for the Prevention of HIV, where in Mexico we are part of that coalition, and within the actions there's been a critical pathway where this coalition is looking to reduce 75% of the new infections for the year 2025. So as you can see, for that matter, would be possible to have a leadership and the right political conditions to bring about certain actions that will take us to implement a view for prevention, combined prevention. This combined prevention, what it's trying to get is that 95% of people at risk for HIV have an access to strategy, combined prevention. 95% of women and children in reproductive age to have their needs met, to have access to sexual health, reproductive health, and HIV. The sexual health pillar is within these actions, and it plays an important role for health. This sexual health pillar comes together with the rights and the view of the right to sexuality and pleasure. So combined prevention, as its name points out, has three main components. One part that is biomedical and that is related to certain assets as condoms, lubricants, and the use of also antivirals, which are the ones that is pre and post-exposure prophylaxis. But this view to reduce some damage, some structural part that has to do with all those interventions that improve the right environment to reduce the stigma, discrimination, work against gender violence, and also a supplemental part which has to do with a healthy behavior and empowering and activation of health of people on the different communities, and even strategies as sexual education and assessment advisory to reduce risk and promotion to sexual health, which is a core part for this prevention view. Now, within these actions, biomedical actions, we have the use of antivirals to prevent this HIV infection. We can divide them into two big groups: the PrEP prophylaxis and post-exposure prophylaxis. But what are these? Pre-PrEP exposure prophylaxis is one prevention against HIV to intake a pill that might create some protection in the body to reduce the possibility to get HIV in case that they are exposed to the virus. Now, this PrEP exposure for HIV won't prevent us from TDs. But thanks to the technological enhancement in the last few years, we have seen the opportunity for other therapeutic choices within the same PrEP exposure prophylaxis. This prophylaxis prevention is for people who have some practices or that are under the risk of getting HIV and have a difficulty to use other prevention strategies. Might be people with sexual partners that live with HIV that are not under treatment, or maybe had not reached a viral reduction, because we remember that the people with HIV with a viral undetectable load is very sensitive sensitive, people who have sex with males also, and transgender, and workers, sexual workers, people with sexual activity, and that they don't use condom, they use psychoactive people, and people who use other infections of STDs, or people who had required, for whatever the cause, the use of this post-exposure prophylaxis, that we need to talk about that. Now here you see the other part. It is a post-exposure prophylaxis, PEP. And this PEP allows us to provide those people who have had a risk factor for HIV to be able to have some treatment for a short term, 28 days, in order to reduce the possibility to get this infection. So we need to start it within the first 72 hours, because it's going to reduce very significantly the risk to get HIV. The sooner we get the spread PEP, once they go through the barrier of this virus, it will take 48 hours to replicate. That's why we have this framework of 72 hours, so people can really receive this therapeutic action. It should be included not only treatment, but also some advisory lab tests to assess adherence and tolerance to the treatment, and follow-up of the people. So within these measures of combined prevention, we have these procedures of treatment. We do require different points that will take us to be able to have a prevention against HIV. Within the coalition, what has been coming through, it's a critical path for all countries that, and it's been based on 10 things. The first one is to have a database assessment, which are the needs, the barriers for prevention for HIV, and to adopt a prevention approach to focus on people, on the communities, and key population to be able to reach these objectives for sustainable development, and also to be able to define the needs of investment from countries to be able to have financing funding that might allow the continuity of an action or policy that might have the available resources to make it sustainable, to reinforce leadership in terms of prevention for HIV with a very sectorial view. Remember that talking about sexual health, we are talking about the well-being, physical, mental, and social of the people. Therefore, we need to have a view that is a global view of this sexual health, to get rid of barriers and to generate, through some preventive services focused to the community, these networks, and primary attention to health, and to get rid of all the social barriers and legal barriers that might be an obstacle to have access to attention for people, integration of prevention of HIV in the services which are related in order to improve results and outcome. This means that we need to have a continuous track of attention and the right mechanism to reduce new infections through creating new technologies, incorporating them, and the access to outreach of populations who have hard to reach or vulnerable, to have these systems and programs for a follow-up with periodical reports, and to reinforce the responsibility and accountability of the stakeholders to have a right view going beyond certain strategies that are independent. And that's why we have, additionally, if we want to reduce these infections, to be able to have some cross tools that are the basis and pillars for service and social service, in order to be able to identify the inequalities and to close these gaps in health and reproductive and sexual health, and to be able, without discriminating gender, to take out all discrimination, to have a bisectoral outreach and view, and to be able to have the funding, right funding, and investment which is sustainable to reduce the HIV. This is through integrated networks of services and primary attention to health, and to be focused on these 5 pillars. Key population, which is core, but also not to left behind other people, women, teenagers, young people, to be able to have an approach towards young people, male, teenagers, and programming of condoms, reminding that this is a fundamental core and pillar in terms of prevention, not only HIV, but also unwanted pregnancy and all STDs, and also prevention based on all this health. Within these strategies, this is the main goal is to reduce new infections and to be able to reach these goals for 2025. Now, within this, since we have these biomedical components, SIDA is focused on information and on evidence. The models might help us, both countries, in the main municipalities, regions, to be able to pinpoint which are the choices, therapeutic choices available, because we know about condoms, lubricants. This is a cost-effective preventive measure. You can see which are the differences according to intervention that is taking place, to be able as well to have some guidelines which are simplified and recently updated. And by the WHO, we have a guideline in order to prevent and using PrEP that will make this action simpler based on all this information and data that we collect in the last few years. And in general, to generate these follow-up in terms of resistance and rejection, viral resistance in those countries that have some scaling up in the use of PrEP. Now, which is the reality of our country? Well, in Mexico, we estimate that we have for the year 2022, 370,000 people living with HIV, out of which 7 out of every 10 had been diagnosed. Now, this number, to have 7 out of 10, means that there are 3 people out of 10 that live with HIV and they don't know about it. This might have a negative impact on the health of people, but as well on the control of this infection. Once people know that they have this infection, most of them are related to attention, receiving treatment, thanks to this strategy of therapeutic optimization. And so we see that these people might have these suppressed viral loads in most of the cases. What does that mean? Well, we need to reach these people that do not know they have HIV, but still, if we have 20,000 new infections a year, this means that we are reaching late to these people. We are not reaching on time in terms of sexual education. We are not reaching on time in order to make them this new service available for combined prevention and to be against the stigma and discrimination, and to provide them empowerment to these people and to try to make them to live a different life. That's why, since the center and together with the whole system of health, what we were considering is the specific action program to be able not to just set the goals of viral suppression treatment, but to add some others. Prevention. People should have access to prevention combined services with this global view that I was telling you about, but quality of life as well. Because if people live with HIV, we should not just go to viral suppression, but also to provide them other things. There are some other tools that you can see on your screen. One basic element is to be able to have these combined prevention in mechanisms. But even going beyond that, what we are sure is that for a sustainable response for the prevention of HIV and other STDs, What we need to bear in mind are integrating view. That's its sectorial view, where people and communities are on the center of it, but will take us to create some networks and some actions among agencies, and also to some other elements of directed actions for certain target populations, that to have gender equality, no discrimination, and sexual health programs, and this pillar, which is very relevant. And just seeing the person right away at the center, also through all these actions of empowerment that we can provide, bring about new changes nationwide. So during these years, we have been able to work together in the implementation of this policy for combined prevention, and we will be focused on pre and post-exposure. Before 2019, in Mexico, there wasn't a policy, national policy for combined prevention. It was non-existent for PrEP and PEP. There has other components, such as to have condom, and there was a condom program. This is one of the pillars, but does not include the rest of the basic biomedical therapeutic measures that we have been talking about, But as of 2019, and since con nacida, what we started doing was generate from the regulation the development of specific actions program, where we have academic leaders and public health and other role players and stakeholders in regards to HIV. And for the first time, it included this view of having these post and pre-exposure prevention measures to have a consensus on this policy. And it's starting on 2020. You might remember that also this is through in pandemia, but still we kept on with this response, and to have a guideline nationwide to be able to provide all this information nationwide. But all these things won't be useful. Starting from 2019, we started with some management in order to have the authorization of funding and consolidated procurement, and to have all these inputs nationwide with the authorization of agencies, medication, assets, inputs, and human resources, which are core to be able to implement all these measures. Once that we have the regulation and everything and the funding, we required training. There was a policy that was non-existent, remember, so we had to have national campaigns, online training courses that were developed with this view of integration of the sector, and to be able to generate research for scaling up nationwide that has been taking place as a result of it. What do we have as a regulation? Well, from the program of specific action, our guidelines for attention, and finally this year, the official norm, Mexican norm 1005, that allows us to be able to have all these regulation that is applicable and implemented to provide combined prevention in the country. So this integrated response to HIV should be centered on people and the right to have their own health, protection to health. And we should have to consider prevention, prophylaxis, pre-exposure level of risk according to the needs of people, and also the diagnosis and treatment with an approach of public health based on their rights. In terms of financing and human rights and human assets, well, the input is to be able to generate at the end all this strategy, which is a biomedical, and we need, of course, a follow-up of the kidney function of people who have this problem, and to be sure there are no infections that might modify the indications for the prophylaxis and treatment as hepatitis B, and to be able to have this view of integration of health system. So a consolidated procurement of ARVs for the use of pre and post prophylaxis treatment, but also diagnosis to be able to have a fast track tests of third and fourth generation that might allow us to know or what happens, and to have also all the people who know how to implement it. This is part of the right, health right of people. Within treatment and training courses that had been generated, we have different training courses that include access without discrimination of updating of different strategies, the first level of attention, but specifically pre-exposure prophylaxis, where we find some open periods where people can go there. How many people we have reached as of 2020 to 2023 in terms of pre-exposure prophylaxis in Mexico based on these guidelines? We say, well, more than 350,000 people all around the Mexican territory. And this is a good leap, and this is an effort made to be able to generate and raise awareness and also training of HCPs to be able to provide these actions to people, make them available. National campaigns where we try to generate this information and to bring it closer to people. And in a very transparent way, we have a number, telephone number, and an email number. And this is an automated center that was generated during pandemic for the response and request of population, where people that are talking and registering their call, this is being recorded right away. And this platform allows to have a linkage in between different sectors, and we can have updated information. This has reached also institutional campaigns and state campaigns. So we can see here, for example, in some lymphographs of the IMSS and ISSDE and other health agencies, that this is part of bringing people all this information. And we can create a change, but we need to start with information. Even people know that Mexico has this policy, which is available, which is there for people on the Mexican territory. We need to let them know. On research and implementation, there was also an assessment of key population, and this was done through the community. And the result was that there are some potential gaps on this risk. And then on an implementation nationwide, and we know that this is not just to be able to have these actions that are targeting to provide medication to people. We are talking here about human rights and planning, family planning, and sexual diversity to prevent or some other STDs, and also the pleasure and sexual health. And so this is important identification of gaps to know which are those elements in terms of the gaps from the features of innovation and internal, external, the features of people, and the process through a framework that has been standardized and which is within the critical path that is coming from HIV, and where all these assessments are coming from. Implementation through the primary attention to health and integrated networks of service, community services, and interinstitutional agreements that some agencies have had. At Chiapas, for example, it's possible to be expanding from a view of all institutions, of health institutions, and interinstitutional coordination. Now, among these health service and system, there are 342 units. So if we go by date, we can see that there is or not at the different states how this has been expanding. from the implementation of this policy, but actually, well, it's not enough. And if we go to the view of the availability, well, this is still with some gaps for people. This is telling something about some response elements that we need to close. It talks about the need to generate new implementation services for people to have access, an equitable access and fair access that will take away all these gaps and risk and out-of-pocket expenses.
And for post-exposure prophylaxis, more than 5,000 users. And for people without PrEP, a total of more than 11,000 users. And if we talk about a policy that was non-existent, that has been implemented and scaling up, then we see a change in segment, change in institutions. We have Prevenims, we have the IMSS, which will be having an update in the next days. But from not having anyone in national funding and now having one in a public funding, well, these are the results that are being managed at the government for the implementation of these actions at a national level. We also have a territorial verification in terms that post-ex prophylaxis is an emergency, and we only have 72 hours to act. Hence, it should be in care units, care facilities, and there has to be interinstitutional projects by the health sector and the state commands so that this becomes a policy that has to be followed up, that has to be strengthened, that those kits for quick tests for hepatitis, HIV, all of them can be included, as well as post-exposure prophylaxis for those that require it, the next day pill, among other actions. We have work in coordination with CONACYDA, and there is an action plan where there was a call to action for community leaders and academic institutions, so they participate. They participate in these work tables in order to generate an analysis and successful experiences in implementation of the national level strategy. And let's remember that there is a critical path that we are following throughout the country. And let's also remember that we need to have resilient systems, that at a population level, there is a need for this prevention not to be stopped. It cannot be stopped even if there are floodings, earthquakes, or any other risks, or emergencies, natural disasters, public health disasters. And it is through the creation of resilient systems that we can succeed. A recent example have been some response actions in Guerrero as a result of Hurricane Otis, where there was a series of actions, coordinated actions at CONACYDA, at the institutions with the state and with the program's leadership at a state level, for HIV, communicable diseases, hepatitis, tuberculosis, because if we think about people, then we need to have these preventive action and continuity actions. Here we were actually assembling kits that included continuity and access to condoms, lubes, quick tests, among others, for the integration of interinstitutional actions. And as you can see here, not leaving anyone behind, even during disasters or emergencies. Recently, at CONACYDA's Council, the implementation and update of the guideline for providing PrEP was authorized, was approved. This guideline has been around for for some years now, and along with the WHO's strategy, the aim, the end goal, will be also being aligned with implementation characteristics at a national and international level. But also the pre-ex prophylaxis is done through the prevention committee, and the progress of this committee will be reported by health providers and by communities and municipalities. It is also important to consider that the follow-up of a strategy that's safe is of utmost importance, one that doesn't risk its users, and so that it allows the verification of the biomedical strategy. So what does this mean? In Mexico, the PrEP and the PEP are part of the combined preventive policy. It's a policy where all health institutions participate together, where they manage and double-check at CONACYDA the activities. And we are there to add more input, where each of these people can come to us in order to help them get in touch with the nearest supplier. We have all of the contact info here for you, and only working together as a team will we be able to move forward and to be able to fight this disease. Thank you very much for your attention. Unfortunately, we won't have a round for Q&A because Dr. De La Torre is in Amsterdam in a meeting. That's why she was not able to join us via Zoom. However, we have 10 minutes, so we would like to use these 10 minutes to see if any of you that's already working in program dissemination PrEP, mainly PrEP dissemination, if you want to share any experience with us, because I've seen that there is kind of disparity, not only inter-institution, but also within the same institution. So maybe this is due to the lack of dissemination and penetration of the program. So I would like to know if any of you want to share your experience. Please don't all try to speak at once, just one by one, please. Thank you. Good afternoon, everyone. I have the opportunity to provide information on PrEP and PEP, and at the same time to disseminate further information. I'd like to thank the opportunity. It is very important for us to please disseminate this information, share this information with our colleagues. I ask for more commitment in the medical department so that you know what the processes are. Even though we have guidelines and we have dissemination covered, there's still impact to be caused among the community and the country. We see there are guidelines, there's a lot of information. However, the user comes to medical units and they don't really receive this information. So when they come to us, they come to the clinic, the HIV clinic, they already come with a diagnostic. Currently, the zero discordant partner comes to us, asks for therapy, and the family medical unit is a barrier, an obstacle, because they don't know how to guide them. They don't even know the protocol, how they should facilitate this therapy. In terms of PEP therapy, our bosses and we should know how to guide, and bosses should know how to guide us in turn so we know what to do to provide, to share these emergency kits. I would like to take full advantage of this forum as a call to action to please train people, share information, so we can have an impact on the population, but also on us as health providers. At the unit, I always ask for opportunities to share information, for strategies to be able to reach our colleagues, our bosses, and medical units, so that this way we have more dissemination and at the same time prevention. We have an average of 20 or 30 newcomers a week with a positive diagnosis. So it is incredible how 15-year-olds are coming to our clinic, and prevention is very important for that. But if we all speak the same language, prevention-wise, we are going to cause a positive impact. Thank you very much. Thank you. I think the mic is already working. My experience as a treating physician at OADA Aguascalientes is the following. We have a small delegation, which is why we've been implementing the PrEP program in the 3 different hospitals that we have. We've had maybe not so many people. We have tried to personally promote the institution's response, as well as the one from civil associations with which I also work. Yes, there's more promotion needed, more advertising. We need more advertising by the Institute so that more people join this program. There is not enough information in family medical units. It cannot be that in family medical units, people that go and ask for the program, no one knows how to explain or what to tell them, or tell them, why do you need that for? Or better, when you are already infected, then you can go to the HIV clinic. So in terms of promoting PEP, the PP, I think that internally, our units also need to share information among the operational staff. An example of this is my hospital. The infirmary post-technical training course students are those that promote the program instead of our directors or the rest medical staff. I mean, one would think that the directors should be the ones permeating that information. Of course, not to speak less of infirmary, and the nursery department, the infirmary. But it is important for them to know the information so they can guide people if they have a risk sexual exposure. I would propose maybe consolidating a little bit more the PrEP program, maybe leaving it as not only for second level, but also involve the first level, because maybe by doing so we can prescribe PEP at first level, because that would give us a greater reach, that if we only keep it to the second level. Thank you. I think that Yeah, I'm gonna go with you. I think this is a job for everyone, because if we go back to what happened with COVID, do you remember what happened with COVID? Part of the problem was that we needed more dissemination advertising. If you remember, there were instructions for the use of masks, and in some places they didn't adhere to that, but because of lack of information. So I think that's part of what's going on with the PrEP. Since it is a new program that for many of us So, because I'm sure that it happened to you as well. When some patients came, they were interested in joining the program. So now that it is integrated and we have resource availability in order to include the healthcare staff, I think it's our responsibility to educate, to share information about the program. As it was mentioned yesterday, you've seen that in many places where PrEP has been implemented, there's been an efficacy proven. There's been a reducing case rate. However, it's also important to add, and this is something for all of us to reflect, on those same countries, in the US mainly, they consider that only 1 out of 4 people that could go to PrEP program actually do. So it is not an easy task, and it doesn't have to do with the country's economic situation. So I believe that all of us involved should also commit to disseminating information. Thank you very much. Great day. I am Elizabeth Molina. I am a social worker at the second-level hospitals. I'm in charge of HIV clinic as well. It's been a great experience for 2 years. However, it is important to see what my colleague mentioned infirmary-wise and dissemination. When we got to the program, no one would tell us what to do or what to address. And now that we have the opportunity to talk to many people, we know that there's a lot of information. Fortunately, we were invited to participate and to be able to certify as counselors and accompaniment effort for HIV patients. So it allows us to provide the right counseling to our users. And it was until then that we found out about this pre-treatment, the PrEP, and we started disseminating information. However, I do believe that social work has a very important, a critical role, because we are here to educate. And funny enough, I mean, despite the information out in the media, because we as a network exchange information on training courses, and there were first-level colleagues that are not included in HIV clinics, so the permit for them to attend was denied. So it's very important that from the preventive stage, to inform them so that they can refer to us, the population, but for also to create preventive actions from there. Now, I've mentioned that I am already providing self-help groups and educational segments. When I am asked in units to go and talk to users, well, my authorization never comes. So it is very important, and that's why I'm asking you to please open this channel and to also allow us to be able to interrelate and create a network of support, because there's a lot to do in these activities. I recently heard about it from a chatbot, because when someone came to a social security study, it was that person was asked married or single, with a partner or not. So it was like, well, what about your partner? The partner already underwent studies. What was it? Negative? Okay. Does they have the PrEP? So that's where I have the opportunity to maybe refer to the family medical units or to the internal medicine director. But it's really hard, so that's why I'm asking you for your support, because there's still a lot to do. Okay, it's 12:50 sharp, so we are going to stop this Q&A session and we are going to continue with the next presentation. Thank you. And according to our agenda, the next presentation is about future pandemics and their impact on HIV. And we have the honor to have Dr. Omar Sweat joining us today. He is a physician by the Universidad Nacional de Córdoba in Argentina, and he has a specialty in infectious diseases. He's been working since 1997 in different countries and environments, including public and private hospitals, at health centers, even in prisons and NGOs. Since 2009 and 2012, he worked as an HIV advisor for Latin America and the Caribbean at PAHO in Washington, D.C. He supported emerging countries with international guidelines and supervised the coverage and application of antiretroviral therapies, the ARTs. He also supervised the action plan of syphilis and HIV, and he was director of the nonprofit research laboratory, and he has also worked in clinical, social, and translational combination efforts. He also promotes public services on infectious diseases and communicable diseases, HIV, reproductive health, etc. His work has been included in the network of HIV prevention and the network of vaccinations against HIV. So it is an honor to have Dr. Omar Sweat. Doctor, the floor is all yours. Thank you for the kind invitation. It is a pleasure to be with you. Unfortunately, I was not able to be there in person. However, I'm sure that for next year we will be able to organize it. I will be able to better organize my time, and I will be able to do whatever is necessary to visit you. Every time I've had the opportunity to be in Mexico, this is one of the preferred countries due to people's warmth and the beautiful architecture and the landscape and colors. So, and what about the food? I mean, so I will talk for 40 minutes about a utopia, which is eliminating HIV in the context of many other pandemics that we have or we could have. So when we talk about eliminating HIV, we are not talking about eradicating, such as we did with the chickenpox, which is the only one that has been actually eradicated, but it is actually a definition of public health, of ending AIDS, and this would be lowering new cases 90% and lowering deaths related to what we saw in 2010. So making efforts so all of these red dots can disappear from this slide. And truth be told, there is still a lot of work to do because we see how if the new infections are globally going down 38%, kind of behind to what we would need. But in Latin America, new infections and growing are increasing. And this is quite concerning because this means that despite all of the investment throughout the region, which was one of the first regions having national HIV programs and ART for free, for the last years, we see in concern that there is an increase in new cases. Let's say that deaths related to HIV worldwide have gone down 52% for the last 10 years, but in the region only 32%. So the situation is a little bit better in the Caribbean, as you could see here. But what's changing in the dynamic of the new infections in our region is who's becoming infected. And in general, if you see the pyramid here, and in purple, we have men having sex with men. In green, heterosexual men. And in red, we have women. And in yellow, we have the drug users, and we see how most of the cases that are appearing are in men that are less than 40 years of age. And you see this every day because you work, you do prevention, you do testing, and you also see this in many other countries, in Colombia, Bolivia. And when we look at the amount of people that became infected, for example, in 2021, which is the last year where this type of analysis was carried out, we see how Latin America, almost half of infected people are men having sex with men, despite representing less than 1 or 2% of male population. Or any of their partners. So almost 90% of new infections in Latin America are key age populations. So we actually have to double check if we are focusing on these populations, which are the ones that bring in the epidemic forward. Why should we focus on it? Because if we want to eradicate HIV or eliminate it as a public health problem, there are 4 specific strategies that you all very well know that are quite effective, or I'm going to try to convince you that they are effective in preventing new cases and reducing deaths due to HIV, hence eliminating, which is diagnosing everyone, treat people as soon as possible, prevent new infections, and do all of this with the communities, because as my colleague was mentioning a moment ago in the Q&A session, many times they receive it. They receive the information from their partners or from other type of people to be able to prevent. Now, testing-wise, how are we doing in the region? As you can see, we only have 600 million. With 600 million people in the region, only these countries reported to PAHO. And they applied 10 million tests. It is only 1.5% of tests in a year throughout the region applied on people. So only 1.5% of people had access to testing in the region. And this is very, very little. If we see the programs that have an impact from the standpoint of public health, in eliminating HIV, we see really high testing rates. For example, Cuba, up to 20% of the population, the sexually active population, the same for Botswana, the same from some regions in Canada and British Columbia that have quite high testing rates. However, if rates are low, and besides the positive responses are low, which means that we are only looking in general population and not in key population, then what's going on in the region is quite normal, that more than 20 or 30% of the new infections at a regional level, even though there are some countries that are doing better, such as Uruguay, Peru, or Ecuador, but there are others that are doing worse, such as Mexico even. So more than 30% have a CD4 that's way low when they are diagnosed, which is a late diagnosis, and it is directly associated to the possibility of death, to mortality, as well as other impacts, such as not improving CD4 or not presenting any activation throughout the follow-up. Now, let's remember that 2/3 of deaths, despite all of the progress that we've had, are due to AIDS-related diseases. So there's still a lot of work to do. We have to increase testing so we can improve the situation. And we can do this with many strategies, differentiated testing strategies. For example, tests at home where transgender people live, in communities, in hotels. They see how in these hotels they can receive a visit, and then there is a prevalence of 20%, which is kind of highly cost effective. Also, partner testing. So if you ask systematically to another person that's HIV positive, if your partner asks if you are tested or not, and when they implement this partner testing, then 28% of contacts come back positive. So this is also quite cost effective. Or also the national programs or community programs of self-tests, where the national program via a website, for example, in Curitiba in Brazil, they provide auto tests, self-tests, and those that want to report the results. And we see that among those who reported the results, 37% had never had a test done, and 40% were positive. So there is actually a huge gap. There is a huge need to expand access to tests. Also, this has to be done for STDs, for pregnant women, for the sexually active people that has never done an HIV test. We have to expand these different population with different strategies.
At a health center, we might have the availability of do assessment of the neutral status of people. What do I mean? Any people who come close, we should offer the HIV test. And if then it is negative, to assess risk, to provide PrEP if there is a high risk, or PEP if it's less than 72 hours, there has been an exposure risk. Everything that you do with the primary attention as well, all the needs or disease load that you see on a primary attention. If the test is reactive, we can check out with a fast test and to start treatment and to seek for these diseases, HIV related, to reduce this impact on the death rate. This takes us to the second intervention, which is treatment. Now, this treatment that has to be right away has a very high impact on what we know as undetectable, on the transmissible. And based on some studies made in Australia, if it's possible for community to have an increase of viral load of 1%, this might be making available a reduction of 6% in incidence. This was the assumption through which we started dealing and talking about preventive treatment to make people to be undetectable. That will make incidence to come down. And that's why, based on these findings, this has been an additional factor for WHO and other international guidelines to recommend retroviral, antiretroviral treatment before, without having people in the community that they do not know they have HIV and it's making it transmissible. Most people who transmit this disease are people at the time of HIV infection because they had not been under treatment or with protective actions. In regards to when to start, well, actually, the only guideline that sets forward exactly when to start is the WHO. Most of the other guidelines, they say as soon as possible when it's ready, but WHO, it goes to the point and says it has to start treatment before 7 days. Ideally, the same day if the person is ready, but obviously not people are ready for that because there's a big percentage of people. And I do invite you to do this test with new diagnosis. When you provide information, clear information that it's a viral infection and it's been on blood and that they need treatment, well, they might be happy to start treatment the same day as they receive these other test results of the serology and viral load or some other test that you suggested. This is important because it's not just favoring to start treatment right away. Much more people might claim, yes, I do want to start, compared to what if your appointment, making an appointment every 2-3 weeks to see whether the next results are good. More people have been kept. They have a better suppression on the viral load and less death rate. And this is very impacting because when you receive the patient for the first time, just a few patients on the first 1 month or 1 year, they have gone away and passed away if they start treatment. But this is IP studies of survey of these patients who started 3 weeks before they had the treatment, 6% just passed compared to the ones who started treatment, that just 3 of them. And this is an example of people who are coming too late for treatment. So in your country and your patient that you're given a treatment and he shows like having an advanced stage or very thin or for low points, it's important to provide him same-day treatment because so we can reduce a 50% death rate. Of course, that there are more challenges. We need to think about, we need to invest time to be able to explain it thoroughly, the HCPs to patients as well. And WHO do recommends rotogravir with other nucleosides as the best possible treatment for people with HIV. Remember that rotogravir, it's very similar to atrodravir. I know that because in Mexico, because of patent problem, they have agreed a special price for most people, and this is good because these molecules are similar. The only limitation is that bictegravir cannot be used with people with tuberculosis, and rotogravir, yeah, it could be used. People who had tuberculosis. Why rotogravir? Well, because it was over than efavirenz and two protease inhibitors, and because in all the surveys where we compare it with other drugs, mitentegravir or rotogravir, it was dolutegravir, it was possible, it was similar, it was comparable. There was no survey where dolutegravir shows worse than the other comparison. So we have lots of evidence of the efficacy in terms of reducing the viral load, the time the people is undetectable, and how the treatment is doing well. We have good evidence of high genetic barriers because there's just a few cases that do develop resistance to rotogravir if they start treatment with this drug for the first time. There might be some emergencies on resistance in people who have had these different treatments, especially if they had been using rotogravir before. But when these are naive patients who start with rotogravir, well, there's just a few emergency to resistance, especially for bictegravir. So they can be peace of mind in the country where they are using this drug. Now, despite of this, there is a 66% of people in Latin America with undetectable viral load, and we see how there's a concern because these figures are even worse in children or in other population, selected population, people in inmates or people who have males having sex with males or sexual workers. That's why we are planning or seeking different choices of treatment. There is good expectation with in these long-term retrovirals, antiretrovirals. They are very expensive. They are not generic, but we will be able to have them from 2026. I wish that Mexico might be able to incorporate them at that time. But all these line of research shows a positive and optimistic view, as Claudia Cortez was saying yesterday. All the new retrovirals which are being under assessment, which are long-term injectables, because we have good oral drugs now. So the need is for things to make it easier and even more tolerable. And to tell you that in some programs, tapping programs for people with drug users, illegal drug users, or people who have problems of adherence, the use of these injectable drugs had shown that they recover up to 75%, the ones that had undetectable viral load. What might change the view of what we are doing to get rid of HIV is prevention based on PrEP, that it prevents the other infections, is safe. We just need to treat three people to avoid a BH transmission, and this is important compared to 100 in the case of atorvastatin for cardiovascular problems. And it improves life. It's very affordable because there are some generics available Mexico can have access to, and they have a very high impact on public health, positive. But if we go back to the time of treatment for prevention, if it would be possible to treat all people and to have them undetectable. This is what happens in Australia. See how the new cases might come down, new infections, but just a few. These incidents might be reduced in 20%. So actually, in this point, what we need is to add on PrEP so that it will have a very important response. High rates of PrEP plus preventive treatment might show a possibility for getting rid of HIV. And this also is being validated in other countries. This is just an example of the Julio Montaner group at Canada, where it shows on this math scheme that task or preventive treatment is not enough. When we add PrEP, it is possible that BRO, you remember R0 goes down to minus 0.7. This means that epidemic is coming down. So actually, it's important to be able to add or to bear in mind the relevance that PrEP has to fight, decrease incidents, and get rid of HIV. As an example, you see how in London, until the PrEP started, at the present time, rates were kept stable, and the same at San Francisco. When they started with PrEP, these rates were coming down, and or Scotland, when they incorporated PrEP on the attention infection centers STDs, there was a reduction of 75% for new cases. 75% because these were these STD centers. But when at London there were the outreach in PrEP, there was a reduction, an important reduction, 32% in 1 year. Later in Sydney, that were a control group with these people with PrEP, there was a big reduction in the incidence of new cases. So intervention is efficacious. Intervention is efficacious. That was measured at Peru. It will be good to have the same indexes in Mexico, but it's cost effective because, well, the government is getting money by investing on PrEP, even though that we know what it takes. Other than these additional benefits that we mentioned, that actually a person who is using PrEP as a person who has the cardiovascular risk and starts with statins, they feel this protection, idea of protection, more control with their own body and can enjoy more life in general terms. That's why there's a long way to go on PrEP and many guidelines for treatment. The two most interesting guidelines I want to show you are the one of key population. You can seek this at the WHO or in English, and differentiated PrEP services that propose to have PrEP the same day without the need of having lab tests, other than a fast HIV test to be able to control follow-up faster and easier to extend more the use of PrEP. Or in case of these people who are receiving PrEP, there is increasing a lot since 2020 to 100,000 to 2022. Half of these cases are from Brazil. See how it is increasing the people who use PrEP. And the rest of the countries, Haiti, Mexico, and Dominican Republic, the number of people under PrEP. Actually, it's not going to reach the infectologists or GPs. It's not going to be able for you to make it available to everyone. It will take some time, but we need much more people who might offer it and people who know about it. So that what is important that we should not prescribe drugs. We need to think about the strategy as contraceptives, which not only clinicians but pharmaceuticals and people and pharmacists and people from the nursing station provide them more, so people might benefit from it. So countries like that should favor everything, as Brazil, who already authorized to provide PrEP from the nursing station without a previous authorization. And so with this, we can fight the epidemics. Australia was the country that got rid or announced that they are just about to get rid of, on Brifand conference, to get rid of HIV. And this is very optimistic because we are interested in just listening the cases of these countries that might get rid of HIV transmission. This won't be possible, or it's not going to be possible, without the fourth intervention, which is to empower communities. And in Mexico has been very active in that sense, and they are being favoring it, that we should acknowledge, and also to replicate it to other countries to move forward. This can be done not only through being for it, but providing HIV test and PrEP on the health service and on the first level of treatment. And if we confirm that there is a case, well, we can start doing something. So there are important projects to bear in mind, especially to make easier the availability of PrEP through web page or pharmacies online, or the mobile apps, or to try to widespread it on the places where there is a high risk of transmission for PrEP. And we are just waiting for it. It's been approved already on the USA and by the WHO. Is cabotegravir, and this will has shown to be even more efficacious than tenofovir. But it's very expensive, and so we are expecting for the year 2026 to have some generics. And we can see that cabotegravir might reduce the new infections almost on 36% new infections compared to just to keep the programs with PrEP and tenofovir. And so for the world, it's going to be a very important breakthrough when we have these medications at a very affordable cost. As I was saying, well, we can play with these different interventions, and if we test 70% of population, we see there is not a big impact. People, they know that they have HIV, and they will reduce behavior and transmission in 20% maybe, but it's not enough. If we test and treat all people, it will be possible to reduce 40% new cases. Just a few, as we were showing in the case of Australia. If we test, we treat, we provide PrEP to negative, we can reach 76% reduction in 5 years. And these are strategies which are relevant, supplementary, necessary to make them jointly. The second part of my talk, I want to talk about how we want to get rid of HIV. How is it affecting the possibility to have pathogens and other pandemics, the past pandemics, pathogens that might provide some outbreaks, or hidden pandemic or future pandemic? Well, we had a lot of pain with the COVID pandemic. We see still some activity that is more common, but we see that many people passed away because of this condition, and it has been reduced as of last year, as of today. And it happens in almost all countries who had been under vaccination. But nonetheless, still, there are some cases of passing away, 370 cases actually in the last week of August. On August, they stopped reporting. Let's say that they shouldn't be able to had to report the number of death rate because of COVID. But this is one success on medicine, and also is one of the great failures in the concept that there are still many things we have learned and that we need to go back to set forth as a parameter to avoid it. The first thing we learned from COVID, it impacted fully prevention, diagnosis, treatment services of HIV. We have seen how they were reduced. Importantly, there were big reductions in testing, preventions of HIV, more than 60%, 65% reduction in diagnosis of tuberculosis, 33% of starting retroviral treatment, 28% stopping retroviral treatment. It had an important impact, as you see the number of tests and coverage of women, pregnant women. We see how more than half of people at the COVID time, they did not want to go to hospital, not even to have an HIV test. We see how people, key population, they have in different countries, they were denying attention. 15, 20% of people were denied attention at different hospitals because they have to prioritize other activities. They were reassigning, allotting other activities, and there was difficulty to accept them. But we have known through pandemic the real impact poverty, exclusion, diabetes has, and obesity on the risk of COVID. And it was necessary to adapt the health services. Fortunately, most of these services might be able to have as a standard of treatment the self-test, telemedicine, among other things. We should keep it or not to let it go because these are added values and takeaways from this pandemic. Now, the other terrible pandemic that we had on the region after COVID was this monkeypox and pox. So we had 60,000 cases in our region, 65% of the global cases, 96% male, 77% HCH, and 59% were positive, HIV positive. 80% of deaths global-wise are on the American continent. We see how this is a disease that might be mild in people with HIV. Well, from Colombia, with advanced stage, might be taken longer to treat it. There is a case of 11 months of duration, a case that we heard about, and we can see how serious this disease is when they have an advanced stage of HIV, because they had still monkeypox and the virus to become resistant to drugs as tecomipar on these people, because they do not have this type of drug, the right drug, or they had not the means to contain it. So the indication that these patients should receive a combined therapy would be good, but at the same time to get rid of monkeypox through campaigns, communication campaigns, and to increase the access of vaccination. There is an outbreak, unfortunately, in Africa with more than 3,000 people, and they have no access to minimum, not even vaccination nor any antiretrovirals at the present time. Now, which are the pathogens that are now giving rise to these outbreaks? We have panditissans, we have a vaccine, 99% effective. We have indication of global vaccination, but still some other countries do not provide for free this type of vaccine. Chile, for example, in 2017, they have an outbreak in male having sex with males, and also in other countries, as Croatia, France, and others. And it's very urgent to expand vaccination, especially on adults who had not received vaccine and male who have sex with male, to avoid these outbreaks. Another outbreaks with people with HIV that had been reported in 2017 are the one by pneumococci. There are some at California, Australia, and these outbreaks had been because of subtype C. There are some available vaccine, the meningococcal B, and another one, quadruplex and quintuplex, which has combined A and B and C, WI, which might be advisable to have this vaccine for people who have HIV. Why? Because the fact to have this vaccine might protect them 50% against gonococci. So this might have an impact on people on sexual transmission. That is another hidden pandemic or denied pandemic that we are seeing at the present time. We have more than 30 pathogens that are providing this infection, sexual transmission. 56% of people who had syphilis and HIV. But if we see Porto Alegre, Brazil, well, we have lots of people now having active syphilis. Now, these are the diseases we need to manage properly. And the chlamydia and pneumococcus, they produce infertility, syphilis, 150,000 neonatal death, and the others are also having a very high death rate related to, for example, throat cancer and pneumococcus. There is a big rate of resistance, and there is a big concern. So what can we do about it other than diagnosis of syphilis? That fortunately we have fast tests. So we can use both for pregnant women and key population. And of course, since these are pandemic tests, we need to pay attention to interpretation, because in case of positive, we need to reject that is another type of pathogen, but we have that possibility still. And to use the centers that provide that have PrEP as sentinels or the main centers to see exactly what are they doing. At Rotterdam, at Sydney, they are showing that on these big centers where they have a PrEP test, these incidence of infections is coming down, especially for STDs, because they have these centers that are providing PrEP. And then we have this transmission of mother to child with Chagas and hepatitis and some other syphilis, and this has been contained. Something that is interesting and happened last year was the possibility of using prophylaxis post-exposure on people with high risk. And they are using 200 milligrams of doxycycline for non-protection. And we can see how these new STDs infections are being reduced. And 30% of these people are high risk. They have an STD, and with dosi-PrEP, only 10% could manage it. It's almost been disappeared in syphilis, and it's been reduced very importantly in the case of chlamydia, even though still we see some cases of gonorrhea, because you know that the dose on this has a high rate of resistance, so it's not doing so good. See how in population, HIV population and PrEP, you see how there are protection rates of 87% for syphilis, 55% reduction for gonorrhea, because they have an impact, but not so relevant because of this resistance. But when we combine it with the vaccine meningococci, this gonorrhea comes down much more importantly. Another hidden pandemic is tuberculosis. And so we have 1,300,000 people of dead people passing, and 157,000 people, they had HIV with a late diagnosis. So this and plasmosis is another cause of death in the region. And we have another opportunities to try to avoid them. Toxoplasmosis he was referring to. And we need to start with a PrEP test. We have to use another methods to do a fast test of LAMP in urine. When we add them with the same patient on the first consultation, we have more than 90% of sensitive of detecting tuberculosis. If we add up to have an mobile X-ray with AI, it will be possible to detect all these tuberculosis in less than 2 hours. There had been some treatments, which are new treatments, with medaquinine for the resistant tuberculosis that allowed us to provide a short-term treatment, oral treatment. It's not injectable. So there are new evidence on treatment of short-term 4-month treatment for non-complicated tuberculosis in children, or 4 months for adults with fluoxetine in case of non-complicated tuberculosis. Now, this is a little bit hard to implement when you know, because we are so used to the 6-month treatment and has not been so many changes. What is important to implement is new schemes of prevention. Because of 9 months we used to have with isoniazid, we can reduce it with rifapentinisomiazida, or 12 dose, 3 months, with just 1 intake per week of this medication with the same efficacy and with less adverse effects and more adherence rate for these people. So the problem is that most of patients, the new patients with HIV, are not receiving prophylaxis because doctors are afraid of. They prefer to have the PPD, and most patients who are being diagnosed with less than 304 CD4 is going to be negative, or they never show the results of PrEP. So WHO is telling us not to based on PPD and to decide the prophylaxis in case that the person has less than 350 ppc. There are many pandemics that might come into the future. There are many more that might come into the future.
There are emerging, re-emerging, and those that can appear for the last years, and that's why it is very important to be quite attentive to what we've learned and to be prepared in order to prevent these next pandemics. We know that preparation works at a country level, that health is a matter of everyone. No one is safe until we all as a country are safe, and that's why countries need to provide a clear response that is agile and easy to adapt, and that's why there is a document and an initiative by PAHO called PRED that supports countries to carry out this type of plans and adhere to the recommendations. Now, the goal of these plans is determining that the populations that could be more vulnerable could create initiatives or approaches to address these barriers, these obstacles, and improve accountability as a key element during pandemics. Carry out investigations on how these have been strengthened, as well as the skills and capacities, and the communities that are highly vulnerable, not only due to the activities, but also because of the environment where they live at and how they're conditioned. We see in HIV cases the amount of VBC that you are susceptible to is quite different, but also the populations that have HIV with low-income environments and life situations that expose them to other potential pandemics. Another problem that we also have to address is mental and psychosocial health. And I say this as an experienced, as someone that lived it. Look how my face changed during the pandemic until it stayed like this. And well, I was able to recover after this pandemic. Finally, so it is very important to remember that we have to work on the structural barriers, and the most important one, I'm sure, is stigma and discrimination. And we also saw this in PAHO monkeypox-wise, not talking about diseases, not talking about the risk, it could really affect us. That's why the communities that are the most affected, once identified, have to be the center, the core of this diagnostic and treatment effort. And to conclude, this comprehensive effort by PAHO has 3 different legs: a possible respiratory pandemic, others due to vectors, others due to food. These potential pandemics generate the need of a comprehensive focus to increase efficiency and the usage of existing systems. There is a document, a very nice document for this initiative that's divided into 6 parts. in order to provide further context and considerations for planning, how to adapt country systems, how to adapt alarm systems, what are the activities and operations, and specific materials adapted to each pathogen that could, and this information can be found in the WHO website that each city should adapt to the federal government. So to conclude, hopefully, I haven't stunned you. Hopefully, you believe that HIV is a disease that, just as monkeypox, just as COVID, can be eliminated. And for this, we need to test. We need to use the advantage given by PrEP, by undetectable, because without PrEP and without testing, models, it will be very hard to control HIV. So this is why we have to strengthen the dialogue between HIV programs and others, such as STDs, hepatitis, in order to jointly think about elimination frameworks. And that previous pandemics already shown that there is an unproportionate impact in people with HIV. This is why we have to put it ahead in any planning for a next pandemic, and that the elimination and the preparation of future pandemics have to involve all of us. Tomorrow, which is the World AIDS Day, the PAHO and UN AIDS motto is to give the communities the opportunity they deserve so we can reach everyone that we haven't reached yet, to offer tests, PrEP, and treatment beginning. Thank you so much, and I'm here for you for any questions that you may have. Thank you, Dr. Suez. This was an amazing, brilliant, and accurate presentation of huge elements such as future pandemics and how to eradicate or how to contribute to eradication. Are there any questions? We have a couple of minutes still. And there's a question, actually by me. I'm the first one asking about this testing strategy directly at people's home. I find it very interesting because we have identified areas, regions where even due to or per districts, prevalence could be higher. How can we implement this testing at home without being intrusive, preserving this confidentiality that could maybe be a little bit complicated? Yes, it is always very important to consider offer, because there's a need of an offer, and listen to the response for it not to be mandatory or coercive. And this question has to always be in a framework of confidentiality. So the programs that go door to door, in general, are integrated not only as an HIV testing directly at home, but also as a community health assessment. So nurses go to a diabetes test, go with a diabetes test, syphilis, hepatitis, HIV test as well, and they offer this service to everyone. And they ask for a private place where people living in that home or hotel can be subject to the test. So I saw this especially in transgender women, because in Argentina they live in communities in this type of hotels, and it was quite successful, not only for HIV but also for syphilis and tuberculosis and TB. But there's also community experience, community testing experience in general for these health fairs, as they call them in Africa, with a very high impact in being able to increase to more than 90%, as it was the case of Botswana and many other countries in Africa. So it is always important to place HIV as one more tool, as a diagnostic and preventive tool, and always offer it, wait for the response, and then, of course, not being coercive. And it has to be done confidentially. We have a question. Thank you, Doctor. Good afternoon, Dr. Suer. Georgina Gutierrez here from the Positive Mexican Citizen Movement and the Positive Women Caribbean Movement. Besides, because I've been thinking about public health, we are also considering including collective health, doctor, because the motto, and I'm going to change a little bit, which is leading communities so that communities are first. So I think that collective health gives us the opportunity to bring back knowledge, wisdom to communities and acknowledge it. So not from physicians and scientists that are the ones that have the knowledge. But I think that during the Congress, we've seen again and again integrating communities as part of the response. So we cannot do it from the government nor from social institutions, but that we have to integrate communities. In Mexico, it's quite hard because of the federal government, and they think of civil society as enemies, but not as partners, that we could keep articulating the answer, the response, because we've been doing it for almost 40 years since the pandemic started in Mexico. But this is a question for you, doctor. You are a member of PAHO. And another element that concerns me is in this world of men with PrEP, this option of not becoming infected with HIV is offered only to men. Yes, I understand they are a key population, but it appears as if women are outside of the sexuality exercise, deciding if we want or not to use a condom. I am a fan of the condom because I know that it also protects me from other STDs, not only HIV, but I do believe that it is like a patriarchal type of viewpoint, a chauvinistic one, a machistic one. So I'm glad that you mentioned sex and pleasure, exercising sexuality and pleasure. But it catches my attention once again how women are out of strategies. We are left out of the strategy. So when are we included? And we have to once again deposit our sexual health on a man that's having sexual relationships with men and women. Maybe they are bisexual that haven't come out yet, and they are still going to be an infection transmission breach, and we depend on them, but I don't depend on me, in a world where most of us, women, are the ones that populate the world. 52% of population in the world are women, right? So I really ask PAHO, doctor, with all due respect, of course, that we have to be included in their decisions. We cannot keep depending on men's decisions, especially in these matters. And I also see in terror all of these syphilis and the rest of the STDs, but this is an invitation to have gender perspective when you create these policies. I don't see it. I don't see it in Congress. There is no work table that has addressed women or prevention and the historical death with children that still are born with HIV in the region, in the world, in the country. So very respectfully, doctor, I do recognize the effort of the IMSS, Inter-American Center. I do, and I applaud it, but I don't see any other strategy. I do applaud the civil societies, communities, because there is an absence of strategies for these 6 years that we've been in the current administration because of the way they look at us. That has been unfair, inequitative, and they see us and they hear us, but they just ignore us. So it is just this invitation, very respectful invitation. Georgina, I love your comments. I love your intervention. And also, in some way, the opportunity that you give me to clarify that the fact that the focus of PrEP strategy is for people with a high risk of being infected with HIV is translated in MSMs and transgender women, it does not exclude the possibility, not the possibility, it doesn't exclude the obligation that we have from public health to offer PrEP to any person, and that includes any women that's in risk, in such a way that when maybe I wasn't clear if I propose this as a strategy that has to be in common for everyone, but you have to invest in focusing the population that are affected the most. Because if you look at the risks of a young, gay 18-year-old or to 29-year-olds, it has 400 times more risk of becoming infected than heterosexual male. And if we compare this to a woman, kind of the same age, then it's not that we are excluding heterosexual males or women. We have to offer PrEP. Actually, PAHO proposes PrEP for anyone that asks for it, anyone that has an STD, for anyone that lives in high-rate regions, and also with a Latin American focus on other key populations such as sexual workers, both male and female, MSMs, transgender people, drug abusers, and substance abusers. And this has been a mistake, or it has been a result of two situations that we can conceive together. On one hand, the structure of Latin American health systems that has been based in mother and children's health, so it excludes men from public health. So this need that we have to bring to the primary care center, because we only have people trained to treat pregnant women, it's forced to be considered as healthcare providers for postmenopausal women, men, gay men that has never been thought before. And on the other hand, the great effort that we've done for the last 15 years in eliminating maternal and children's HIV. If you remember, in 2012, the elimination along with syphilis, it was huge in the region. But as an adverse event, it has generated for 80% of HIV tests that are done in a country are only done in pregnant women. So if you look at it, there are pregnant women that receive 5 tests, which means that the population testing rate in young people, youth, men, women, non-pregnant women, it goes down, because the effort of the national HIV program is pregnant women, and it's not wrong, but that should be an effort by the maternal plan to make sure that no child will be born with syphilis or HIV, and the syphilis and the test should be focusing on risk men and women in this type of population. So I think that women's debate is very important. I think that there is a crisis of gay advocacy, because actually we are not seeing, the old models of gay advocacy during the 80s to ensure antiretroviral treatment, the ART treatment, have disappeared. And today, gay guys are the ones that are most risk, but they are not including any advocacy. There's a PrEP placed in a country, but no one asks for it, or there's very little knowledge of it. There's no good youth leadership. For gay male youth leadership that's advocating for access, and there should be, because cheap option like this. And I would like to, yes, recognize and acknowledge the strong women's movement that has expanded not only risks but also vulnerabilities, because they are exposed to this, right, to violence. So in this sense, it is also very important to acknowledge. And it's also important to add that we are leaving many other populations outside: migrants, people in jail that are deprived of their liberty, and other ethnic minorities, etc. So thank you so much for opening my mind up to this. Hopefully next Congress we will talk about vulnerabilities and risks that include women as well as other populations. Thank you, Doctor. And my last comment is just to remind you that SDG 5 talks about gender equality and taking into account that women also live in many situations of violence, including sexual violence, and that PrEP could be an option so that they do not become infected with an STD. Thank you. So, Doctor, you're invited for the next symposium. Hopefully you can join us in person. And now we will continue with the next activities. Please, a big round of applause to Dr. Sweat.
El orden que digo. Sí.
¿Y usted nos dice que empezamos, Sí.
Hola, buenas tardes.
Good afternoon, everyone. So we are going to continue with the research work contest modality oral revision. So I would like to introduce the two examiners that are going to join us today. We have Dr. Ricardo Escamilla, head of the public health sector of the National Autonomous University of Mexico. And we also have Dr. Emilio Dominguez San Martin. He's also professor at UNAM, but at Tlaxcala's branch. They're going to be joining us during these presentations as examiners. Today we have 3 works to be examined. 2 are political and social, and another one is clinical and epidemiological, for which I'm going to ask the person that prepared the ethnobiography of HIV. Do we have the author of this work? Sorry, first we are going to have HIV and syphilis screening in people living and surviving out in the streets in the touristy corridor of Mexico City during December 2022. Please, Dr. Felix. Thank you, Doctor. Dr. Felix is participating for the political and social stage. You have 5 minutes to present, 5 minutes for Q&A. Good afternoon, everyone. Let me introduce myself. I am Felix Damas Maurin. I'm a student of the medicine career. I will be a pre-graduate studies student very soon, and this work has been done along with my colleagues Torres Cruz Mariam, Antonio Esquivel Cindy, Aguilar Reyes, Ruby Guadalupe, and Herrera Hernandez Jimena, entitled HIV and syphilis screening in people living and surviving out in the streets in the tourist corridor of Mexico City during December 2022. So before detailing on the work, elaborating on the work, I would like to provide some general overview. This is the definition of those living on the streets, homeless people, and its definition according to the Wellness and Inclusion Minister, which is a diverse group of people that live on the streets and survive by their own devices and that are not enough to address their basic needs. We could describe this as a phenomenon since it is a result of different factors such as extreme poverty, marginalization, social injustice, and inequality in access to opportunities such as access to dignified housing. Now, what do we know about this population? The last record that we found goes back to 2017 as a result of the street population census, where it is reported a total of 6,754 people living in a homeless situation, out of which 4,354 are located in public spaces and 2,400 in shelters. Now, out of this population, there was a report of 87.27% reported as male and 12.73% reported as women. Besides, the age group was identified at 93.95% of them had an age range between 18 to 59, 1.9% are children, boys and girls, and 3.74% were adults, senior adults. Now, the different causes that make these people become homeless are diverse, but the one that was reported as the main cause in this street population census were family problems. For example, exclusion from the family circle due to their sexual orientation, also if there are women that become pregnant, and also those that are affected by violent situation, by domestic violence at home. We can also include drug addiction, economic problems, and also physical and psychosocial and mental health problems. STDs are also a problem a very important problem since due to the already mentioned characteristics, additional to a lack of access to an effective healthcare system and preventive measures, effective ones, this population has a higher risk to be having these diseases. So this is very important. We have to include the HIV or the Treponema pallidum bacteria that causes syphilis because they have a higher potential to have a deadly outcome if they are not addressed properly.
That's why we believe that it's important to know which is the outlook of these HID, BHI, or syphilis population of homeless. As part of our work, we want to come close to these people to know what happens on this population in Mexico City, which are homeless. That is when 2015 to 2016. Now, our methodology, we are part of 5 health fairs that happened in Mexico on December 2022. And in different places of Mexico City, as might be Plaza de la Concepción, and also Plaza de la Soledad and San Fernando Jardín. And we were just a few groups in these fairs, and we were part of reproductive and sexual health group. Our strategy was divided into different phases. We started with registration of data, and we asked people to sign something that they accept to be part of, to take and process a fast test. We know that they have a higher specificity, fast test for detecting and or test to know whether they were suffering from an infectious disease. We were providing right away the results. In case that we had some doubts, we started doing a second test, and we provided this information to, or were making people to go to the center at Condesa. We were providing results, and then we provided some advisory about the use of condoms, and we were giving away some condoms and lubricants, water-based, and we were providing some information to them. On the results, we did a total of 257 tests for screening HIV and syphilis, and a total of 137 tests were carried on for HIV, 6 positive reactive results to women, for men, and they were at San Fernando Jardín, and 33% at Plaza de la Concepción. For syphilis, there were 126 tests with 25 reactive tests. Results, 12 women, 13 men, with a percentage of 56% at San Fernando Jardín, 28% Plaza de la Concepción, and 6% Plaza de la Soledad. I am showing you a chart showing the results, and depending upon the different variables, with the locations, the age of the patients, and the place where these tests were taken. Which are the important results we consider in our research? Where we have a higher number of reactive cases of syphilis and HIV at San Fernando Jardín, there is a higher risk of contagious in this case, and also we did most tests, but also there is a higher risk of how they had these infections. We have a high frequency of syphilis as well. Syphilis is an epidemic. Well, yes, it's an epidemic, silent epidemic in our country that is not being taken into account, but there are plenty of cases distributed among population with a total of 25 reactive tests, positive tests. The distribution of reactive cases obtained was similar both male and female. As we know, on general population, this distribution is different with a ratio of men-women, 8. Every 8 men who receive HIV result, 2 or 1 receive the diagnosis of the same HIV. And also, we registered 3 cases of co-infection by syphilis and HIV, 2 men, 1 woman at San Fernando Jardín, by supporting the idea of higher risk of transmission in this case. As a conclusion, we can conclude that the probability of getting HIV and syphilis in the population of homeless is there, and the distribution is similar on male and female. People homeless are facing social exclusion. They cannot access health services. There's a risk for having infection and lower likelihood of providing the timely attention. It's necessary to implement the strategies to provide treatment for this type of population, to endorse that they receive this screening test for STDs, and considering them as a right for these people. There are some references here, and that is all for me. Thank you so much. Okay, so are there some questions, Dr. Escamilla Gotul? Oh, you have a microphone if you have questions for the person who just presented. Thank you very much, he says. Congratulations for your work. I have 2 questions. One has to do, how did you tackle the informed consent, especially for the type of words and the wording, and how you are explaining to this type of population what is the matter in order for them to accept participating in this project and the benefits there might come about specifically for this type of population. And about the advisory, how did you tackle that part? How was that planning being made to be able to provide advisory to this population with a language they can understand? And also, in regards to screening, that will be my second question. There should be certain criteria to be implemented, the screening to population, among which that it should get a benefit, provide a benefit to this type of specific population. And I would like to know which might be the strategy, because other than you referring these people to Condesa Clinic, how are you sure that they will have a follow-up in their condition? Well, in regards to the written consent, well, we asked informed consent, and we had all the documents with this consent. We explained the whole process, what it means to have a test, and with a language that will be understandable for them, that they were going to be pinched on the finger, and that we explained that the test might be very fast, and trying for them to understand what were the foundations of the strategy, what was the benefit for them. Actually, many people of this population were the ones that come close to ask what was all about, because they were reading a poster claiming STDs or HIV, and they were coming closer to us to ask us. In regards to the benefit for this population, we know that follow-up to this population is complicated. And it was possible to reach them because of Cico Calle. Those were, they were the ones who had more easy way to get to them, and they allow us, this group allow us to come close to this type of population, homeless. Honestly, we as clinicians, physicians, we were just constrained to do the test, to provide advice, and to inform reactive cases or non-reactive cases. The follow-up was more in the hands of Cico Calle, that's the name of the group, because they have the direct contact with this group. They already have a relationship based on trust with these homeless, and they were in charge of doing surveillance of the follow-up of patients. For syphilis even, there was a prescription for them to receive treatment the same day, where they have the reactive outcome of syphilis. All our strategy was planned earlier. we received the support of psychologists and clinicians who had been working with these homeless, and they informed us about what type of language we can use with these people so that the communication to become efficacious. Good afternoon. Well, first of all, I want to congratulate you because you are it's not easy. You are very new, and it's not easy to come here and to present this work. In regards to follow-up of patients, remember in your education, all these programs should be holistic, and one of the important points for these patients is the follow-up, strict follow-up. For example, we have to pinpoint the syphilis patient. We need to provide treatment and follow-up to see whether this condition is improving. Remember this, and congratulations. Thank you very much. Thank you, Dr. Felix Water. Thank you very much. Now we have, please, I want to ethnobiography of the technography or the democracy, paperwork in Mexico, and he's going to talk, he will be talking about this topic. He comes from, as an activist as well. Oh, you are the PhD student, and he's an activist, a human rights activist. So you have 5 to 10 minutes. Ethnobiography of Bureaucracy for the Attention of HIV at Guadalajara, Mexico. That's the name of the topic. Good afternoon. I know that you are, this is the last talk. I am Eduardo Vizcaíno. This was a work in collaboration with Emmanuel Flores. He's an activist of Coalition of LGBT Plus. And, okay, next one, please. Oh, I need to switch. I'm used to this classroom, and you ask your peers to move the slides. Well, this study that was being introduced was a study that wanted to respond vis-a-vis the situation we are going through at Jalisco when we provide attention to people with HIV. When they require this medical treatment, but also there is a health system that is fragmented, partitioned, and that might provide services or attention or follow-up or guidelines that might differ, and within this, we have to identify the access to health services. They go through a system, and within this system and this daily life, and we find ourselves situations that we can define as bureaucracy, red tape. And this type of survey had been using for ethnography, and we want to show you, just to give you an example, somebody who has gone through coming 2 minutes late to the IMSS appointment, and they say, "Oh no, I'm sorry, I cannot allow you to go to the doctor." Who has been through that? Show hands. Maybe each one of you have an explanation. The person who couldn't wake up early, or the person who had an accident or an event. But ethnography, what it's looking for is to know why. In both parts, the user, what is going on, as on the health service, what is going on there. And despite there is a guideline and structure that if you arrive more than 5 minutes late to consultation, or not at all, that everybody should come 10 minutes before, there is some results, bad results. And everything might be implemented into something, all situations. But what about the chronic situation that the person needs to come to this situation? At HIV, people need to come back to the clinic in a systematic way. That's why we are proposing a qualitative study, but we are seeking to recover that part that is ethnographic. How was the going to this user, going to the clinic, and after when he was to the clinic, and he had a peer advisory or not, other people with a similar diagnosis and with a know that what is going on, they are there with him advising, and this work tries to know what is going on with the person and what happened at that time when he goes there to consultation, who answered, what happened to them. On behalf of biography, we need to think about which were the factors, or Emmanuel and myself, we were part of the group going with these people to consultation. Within methodology, the context of attention to HIV is non-uniform and is provided by different health services. We have the IMSS as a provider, health provider, the Ministry of Health, the SISE, ISSTE, PEMEX, and CAPACITS. What do we have at Jalisco? At Jalisco, we have IMSS. We have 3 sites, which are attention services and hospital service. And from these 3, the patient, the case I'm going to introduce, should go through the 3 with different responses. I mean, and capacity that has been created as a new one. Within Jalisco, well, people who have the right to go to the clinic, there are 3 specialty clinics where they are being referred to. People who had gone to all these diagnoses had been on the State Council to Prevent HIV. This is a state-wide program. They had been in charge of linking with the social associations work, the screening, and the work they have done to refer them to institutions. Who's been accountable to see which is a linkage? Well, COESIDA. This is an arm of the Ministry State Department. I'm mentioning this because the case I'm going to introduce was a person who was diagnosed in 2021. The person was 41 years old, male, homosexual. Okay. He was living at the metropolitan area, Guadalajara, and he was homosexual. He was unemployed. He was coming with a relative, a sister. He had had a reactive result during. It just came back. One before, okay. No, this is the right, this is the right one. So the patient was with a relative, and he had a reactive result to fast test for HIV during 2021. After having this fast test on the ER of the old civil hospital, he's referred to a social society. These civil societies at Jalisco from 2018 are societies that start including STD treatment and provide the pre-exposed prophylaxis. One of the main decisions is that the hospital, ER, having a HIV highly specialized area, was suggesting the person to go to the civil society, which has no infectologist or a treating doctor for HIV, because of the waiting time, they claim. How was the patient? Well, the patient had a diagnosis of tuberculosis, miliary tuberculosis, together with HIV. He had started lost loss 1 year ago. He had a deteriorated health status. He had lost 18 kilograms and some skin problems, sarcoma, and also infection, hepatitis B that had created, and dysfunction at the liver. So this is like a summary. So the person was aware of. He was really with bloated feet. He couldn't even walk. He was very tired, and his health was deteriorated. He was afraid that what is going on? Why have I been wasting or losing my weight? And he was feeling so bad. So people, when we feel bad, we don't always go right away to the physician, but there comes a time when we are afraid of what is going on. Then after that, there is a process of referral. So I call it, this is the hot potato, so to speak. This is part of my thoughts. What happened to the patient when he reaches the HIV of the old civil hospital? The non-medical staff was given an appointment for 6 months for the first contact with a physician. So the person was he had it happened in 2021 and he had an appointment for 2022. After this situation and accepting this going referred to civil society and that ER was sure to send him, refer them, and then we contact people from COESIDA and he was also referred to another hospital. And once we went there, what the treating doctor did, well, to ask if he hadn't had another diagnosis than HIV, because the person had a negative HIV test, negative from 1 year ago, despite the fact that he had more than 4 tests at the time positive. The doctor, the clinician said that if he had thought that maybe there's going on something else, and the decision of this doctor is just to wait for the CD4 viral load results to make a decision and to confirm or maybe to reject that it was an HIV. So we decided at that time. Oh, 2 minutes, okay. We decided to inform the doctor if it was possible to advise her with more information, and the doctor felt attacked, and the answer was that we are breaching her medical decision. Any implication is our own responsibility, despite the fact that we were offering a confirmed test at the civil society. They can pay for that. And if she requires something that was unexpected, to provide medical attention. Meanwhile, the decision of the doctor is to send her to ER, to Tesequipan Hospital, where he had 2 HIV tests, and they were reactive. And then he was referred to the HIV clinic to the old hospital. And so the treating doctor was seeing him only far away, not clinically speaking. Once that he sees him, we ask him if he can be attended, and the answer was that the head of the HIV unit is that she was not going to do something, that it was to COESIDA, because in Mexico we have Salvar. This is a retroviral treatment, and this doctor, to provide attention, decided to release him from discharge him from this hospital. And they say that this documentation was not going to take place because the head of the unit said no. We came close to this doctor and said, well, you can change it. And she said no. The head of the unit decided that it wasn't possible. And we said to see the patient is outside. And she said, okay, and she is deteriorated, need to be at hospital. But no. And so what we decided to bring him to the HIV unit of the new hospital because of the decision of the 2 advisors. He was hospitalized for 4 days. He was taken a biopsy, and after 4 days he was discharged because he was going to be as an outpatient in an outpatient treatment. These are all the answers. The family is concerned, is really misled, and the diagnosis is questionable. Why he's not receiving attention? Why the head of the HIV clinic did not accept it? And the peer advisors are concerned about this deterioration. And 22 days after this diagnosis, he passed away, and he never had the opportunity to go there to the consultation. He was just waiting for palliative treatment. He was given for morphine, maybe, but it wouldn't be possible. And that's the way how the case of this patient is. These are the conclusions. Theory of red tape on everyday life, is something that might allow us to identify these times that for the system, nobody was acting poorly. They were acting following by the book and according to red tape. But in reality, it might have a different outcome on the health of the patient. We don't know. We don't know yet. But the patient passed. The sister, one thing that she asked us for is to try to outreach this information from the experience that we have. It's important to talk about it, but to point out that health services are keeping these type of structures because these situations, and I was asking you before, who in 5 minutes had been denied a consultation? Who has denied consultation in 5 minutes? We are part of it, and the system is also part of it because it's convenient for some things. Might create a disorder, maybe. It's not a disorder. People with more vulnerability are the ones who have more difficulties. If we open the door, we open the door to many more people. This is part of my thoughts that you should consider. Thank you so much for your attention. 5 minutes for questions. Okay? And for the examiners, doctors, you have a question? Yes, we do. Hi, doctor. What was the follow-up given to this case? Because once that you have all this information, talking about quality, what was the follow-up to improve that process? After, what happened is to submit a complaint because there were other 2 cases that passed away because of this whole hospital. There was a demonstration out of this Department of Health, and this collective compliance, or denunciation and claim was there. So everything happened, and there was a new capacity. But the institutional response was that they had an over demand by COVID. So vis-a-vis this institutional follow-up, despite the fact that civil societies were adding up to submit a claim, there are some articles on the newspaper, but the outcome, the last contacts were with the sister, asking ourselves if it would be done something different to explain everything, because even though this person passed away, nobody was doing a follow-up from the medical viewpoint. Nobody was accountable before the sister. So the family is looking for someone to get some information and guidance. I congratulate you. This is an interesting case that you introduce. I don't know whether from all these steps that you follow, and there were some mistakes along the process, you have a list of which are those processes that should have been easier and changeable to submit a proposal before the institution. And he answers, well, as simple as this, not to give an appointment of 6 months to everyone generally. Actually, that was a recommendation. The old civil hospital and the new one, they never wanted to sit and talk with civil society on the same table. Despite this case and the complaint before the commission, there was no dialogue at all. But what we were asking is not to give an appointment for 6 months, to have a first assessment, medical assessment. This might make a difference. The problem is that people who are doing diagnosis are civil societies. We need to have infectologists or treating HIV doctors, or the state needs to take responsibility in this diagnosis, how to prevent it. There is a response that might be the state and responsibility, but in daily practice, these things happen. People are having these situations, these experiences. So the capacity that was created has been given some response to some things, but still, and this is a critical matter with red tape and paperwork, they are covering the inefficient parts. It's not a machinery that might become perfect. We are human beings that unwilling needs and political decisions, we can put at stake the life of people.
Ahora sí vamos a pasar al tercer. Muchas gracias. A continuación.
Okay, so now we are going to continue with the third work presented The title is CD4-CD8 ratio as a risk marker to present cardiovascular disease in patients living with HIV under ARTs. And now we are against the clinical epidemiological category. Hello, good afternoon, everyone. Great. Good afternoon, everyone. My name is Alma Jaimes. I am infectologist by the specialties department at the Medical Center 21st Century. This is a project that we did at the clinic of patients that we see in external consultation and our clinical practice. Well, the title, you already heard it, and we know that as it has been seen throughout the Congress, we have many new cases in our country, and the mortality rate is still 3.5% per 100,000 inhabitants. And despite, I know that it varies a lot depending on the state and the hospital, but we have a treatment that gives the proper virological suppression. However, despite this, we've seen that PWH have a higher risk to suffer serious events unrelated to opportunistic infections or to AIDS. So cardiovascular events, such as the cardiology doctor told us the first day, are unrelated cases, unrelated to AIDS. So there is a double risk to suffer from any of these if the patients are living with HIV, if they are PWH people, than the rest of the population. And this is due to a chronic inflammation that, despite having a virological suppression, there is a chronic inflammation due to the CD4 cells being affected. We also have another problem. The cardiovascular risk assessment scores do not take into account this, the immunological profile, or they don't even take into account having HIV as a risk factor in itself. So looking for another marker that was easy to assess during the clinical visit, we found some articles where there was a CD4, CD8 ratio lower than 0.6 could be a useful biomarker to assess the risk in this population. So the goal, the objective of this study was determining if there was a relationship between cardiovascular events of any type that were measured, such as stroke, MI, with a CD4-CD8 ratio of less than 0.6. This was an observational retrospective study, a cross-sectional and analytical one. And we included patients that were in external consultation that had a virological control for more than 3 months. We assessed the baseline characteristics, and we did a prognostic stratification according to age. And also we assessed if there was a relationship with this index and the appearance of stroke. So I don't know. Oh, yeah, you can see it. This is a table that we did to stratify prognosis, and we did was divided it between older than 40 and younger than 40, because cardiovascular risk scales that are used in the clinical practice do not take into account patients that are younger than 40 years of age, because it is not frequent to have a cardiovascular outcome. However, as we can see here, we did have 2 cardiovascular events, 5.2% of our population in those younger than 40 years of age, unlike those older 40 years of age, where there was 4 cardiovascular events for the 4% of this assessed population. Of course, these are small numbers. However, as you can see here, out of the clinical characteristics, the ones that we found, despite being young patients, we do have a prevalence of patients that show dyslipidemia, mainly hypertriglyceridemia, with altered LDL values. which is most of the population that's Mexican, but this plus HIV plus the use of drugs, well, long term, is gonna cause problems. And the only thing that we did was a table of 2 by 2 where we divided patients that had some cardiovascular event against patients having a low CD4 CD8 ratio. And here what we found was an OR1, and this shows that there is no significant difference. So what we've concluded with this study is that this particular marker apparently is not useful if the aim is to find probable cardiovascular events for the future. However, it is worthwhile checking in our clinic because we know sometimes we have a lot of patients, and if we ask for an ECG, then it takes a while, or a Doppler ultrasound, it takes a while. So what we can is look, especially in young populations, what other factors can we modify that could reduce risks and cardiovascular outcomes in this population. And that will be all. Thank you. Sorry, so the methodology was not really clear to me. So is there any specific time that you have with the disease? Well, no, we included it in the database. We imported it in the database, and the only factor was that they had the most virological suppression for at least 3 months after starting treatment. And what was the evolution time? The plus minus evolution time of the disease, I don't really remember the data, but it was kind of 5 years, I think. That maybe some diagnostic had been done, like the meantime, because there are patients that afterwards had somewhere a syndrome and the test is done and they are seen immediately, but there are others that may receive treatment, suspended it, came back, but like diagnostic evolution mean is 5 years. And suppression was immediately after treatment was provided. Normally they go to virological suppression after 4 or 6 weeks approximately. Thank you so much, doctor. Thank you so much, everyone. So with this last presentation, we conclude the oral work and paper contest in the political, social, and clinical epidemiological classifications. Hopefully you have enjoyed this contest and that you can help us next year participating with these new ideas. And so we are going to start with our lunch break now. Thank you.
decía que lo que me parecía interesante es esa...
Sí, para identificar los factores de riesgo. Ah, sí, algún antecedente, ¿no? Pruebas, tal vez tratamiento incluso.
Eso lo empezamos a hacer después. Toda el universo
No lo
lo
percibo.
hicimos con una organización.
Sí, claro. Ahorita se le acercaron varias personas para preguntarle cosas. No sé si sobre esto, ¿no? Perdón, maestro. Muchas gracias. Vamos a ver. Sí, muchas gracias.
Buena tarde. Un aviso, si en el auditorio se encuentra María Alarcón, Leonardo Fabián Yáñez y Livier Velázquez, o si alguien los conoce, les puedo decir que se dirijan a la mesa de registro, por favor. Y en un momento comenzamos ya.
Good afternoon, everyone. Thank you so much for your patience and for staying with us today. Most of the interest is shown by the amazing number of guests that we still have, attendees that we still have. But I know that Mystery has you here, so I know that you are very interested, and very soon we are going to let you know who's been the winners of these free works. Thank you so much for sending us your papers. It's a core element of our Congress. So now I give you the coordinator of the working committee, Dr. Monica Rivera Majey. She's the coordinator of the epidemiology department. Good afternoon, my dear attendees. I am very pleased to share the summary of what we've been doing during the Second International Congress update of the IMSS on people living with HIV, societies working together to reach the goal. So we have satisfactorily carried out the contest of the Second Congress. Also, it's important to add how the contest was carried out this year. There was an invitation issued with two participation sections. The first one, clinical and epidemiological, and the second one is political and social. Through the CISS webpage, the semi-structured summaries were uploaded. The summaries were assessed by peers, which means that there were two examiners of different areas examining and reviewing the work. So in the epidemiological section, there was an expert in methodology, whether it's a statistician, physician, mathematician, and another expert as a treating physician, whether infectologist, internal physician, or any other specialty. And other healthcare professionals also supported us, infirmary, nutrition, social work. And for the assessment of political social papers, it was also assessed by peers, but from different areas of expertise in public health and different specialties, activists, So it is very special to us to have had examiners that supported us in these two sections. We have 53 examiners that, as I mentioned before, come from different institutions and different backgrounds and different universities. Some of them are from the Inter-American Conference of Social Security, the National College of Anthropology and History, the Development of Anti-Hegemonic Masculinity. Censida also helped with some examiners. The ISSSTE also assessed. We also had the Lindre Hospital, UNAM, the Mexican School of Obesity and Nutrition, with nutritionists that are focused on HIV people, and also the Secretariat of Dominican Republic, the Ministry of Health. So we've had different examiners. I don't want to left any of the examiners out. However, we have had many of them. At the IMSS, they work in the different levels of care, as well as in the standardization efforts. I would also like to thank the head of the Coordination of Epidemiological Surveillance, Dr. Romero Guerrero, that helped us providing everything required to succeed in this endeavor. Now, depending on the modalities, the participants were classified in order to participate in poster or oral presentations, which were presented this year in the digital posters exhibition room. This year there was a technological innovation with digital posters. And there were also oral presentations yesterday and today. Today they were concluded. I also want to add that all of the papers were assessed by peers, as I mentioned before, and the oral presentations were also assessed by peers, the methodological one and the treating area and the political and social were from the latter. 78 research papers were submitted this year. They were more compared to previous year. We had 68, the previous year is 15, for political, social, 53 of the clinical epidemiological area, out of which the oral presentations were 2 in total, 2 political and social, and 9 from the clinical epidemiological section. We would like to thank the membership, the conference, for your participation and dissemination in the invitation of the works, because we've had participation from different authors throughout Mexico, as well as participation from abroad. We have authors that also presented yesterday from Rio Grande, south of Brazil. So I would like to thank all of you for your participation. And it's important to add that the 3 different care levels have participated, and they have done an outstanding job in accompanying us and submitting their proposals for this context from different levels, different OASs and states, because we also had capacities introduced in here. And some of them were Baja California Sur, Morelos, Ciudad de Mexico, Navat, Norte, Sur, Chiapas, Coahuila, Sinaloa, Sonora, Quintana Roo, Chihuahua, and also from the OAT Guerrero. So this is something that's quite valuable for them to come and present their work here. Everyone that has participated, as we mentioned before, are winners because they are presenting proposals that will mean a significant change. And we would also like to add that students from the National Autonomous University of Mexico, as well as the University of Veracruz and the University of Jalisco, also participated, among other universities. And we also have other papers that were sent by different institutions, such as civil associations, civil organizations, communities in Mexico, Censida, Capacita in different states, and research institutes, activists, among others. The elements that were addressed are quite diverse. We can identify factors, adherence to treatment, strategies and practices in the clinical practice, screening, comorbidities, co-infections, prevalence and incidence, studies, cohort treatments and studies, and also transcendental elements were addressed, such as the barriers that influence in detection, care, phenomenological studies, revisions to standards and norms, both educational and focus groups, work absenteeism, among others. It was quite enriching, and definitely this will significantly contribute in improving our care and our processes. And we are here with the same goal, which is reaching the objectives by UNAIDS 2030. And this is why we celebrate the progress, and I invite you to update this information with what we see every day. So we reiterate our appreciation, and we would like to further invite you to participate in future events. We will be welcoming you in open arms, and thank you so much for your participation. And let's continue with the Congress motto: societies and institutions united to reach the goal. Thank you very much. And well, now we are going to reveal the names of the contestants, and we will proceed to hand in the awards. Perfect. So first, we will hand in the certificates, and we will share the winners of the clinical epidemiological section of the contest. The third place goes to the Social Mexican Institute, and the ICSS would like to provide this certificate to Ibrahim Klaus Mahoud. Please, third place. It's this cohort study on pigs that was presented yesterday.
Felicidades a los autores.
Thank you so much for the participants. Please, a big round of applause for the third place. So the second place goes to microelimination of Hep C in people living with HIV by the OAT Quintana Roo Dr. Erandi Prieto, presented in the other room, the sessions room. I don't know if all of the authors are present today. Congratulations, doctor. And the first place goes to for the clinical epidemiological section is for INER, Barrientos Galega Edgar is the main author, Osuna Padilla Iván, Armando Rodríguez Moguer Nadia, Carolina Ávila Río Santiago, Briceño Olivia. Activation of T lymphocytes CD4 and CD8 are associated to the suboptimal consumption of vitamin E, omega-3 in people living with HIV under ART treatment. Thank you. Thank you, everyone. So in this hour, we have a cohort study, which is from abroad, the third and second place, that was at OAT Quintana Roo. Is by the Mexican Institute of Social Security, and the first place was INER. So with this, I mean to say that this is a peer assessment. And these results are from every examiner. Now we are going to go to the socio-political award. It's important to add here that the third place
Perdón. No solamente es para darle un poquito de tensión acá.
Yeah, so just to create more mystery, just to give more mystery to the situation.
Es que ese no es el nombre, es si es la autora, es de Sencilla, pues ahorita lo voy a poner acá. Barreras, no sé, aquí está. Ya. Sí. Bueno, vamos a dar el...
Okay, so the third place goes to but the name of the work is Barriers for Timely Detection of the HIV. This work is from Sencida. Sencida, please, congratulations. Congratulations. Morales Carcaño Anet, González Chávez Guillermo, Bautista Bautista Mayra, Pérez Larios Fernando Daniel, and De la Torre Rosas Alexia. I'm one of the authors. Congratulations.
conservo los certificados. Sí, muchas gracias. Muchas felicidades. Gracias. Un aplauso.
A round of applause, please. Now we will let you know the name of the second place. And this is a research work, Ethnobiography of Bureaucracy in Care for HIV, Guadalajara, Mexico. Martínez Vizcaíno, Gerardo Iván, Pablo Manuel Flores Escobar.
Pase, por favor, le van a
Gracias.
hacer.
Muchísimas gracias.
Very interesting, the proposals. Congratulations. And now, so now we will let you know who's number one, the winner of this research work on social political. And the title is Screening of HIV and Syphilis People that Survive on Street in Mexico City, Homeless People. That's December 2022. These are students of the 6th year, Aguilar Reyes Guadalupe, Antonio Esquivel Cindy, Damas Maulín, Félix Gerardo, Herrera Hernández Jimena, Torres de la Cruz, Mariam, Oret. Congratulations.
Muchas felicidades.
Congratulations. Keep on doing this research work. Okay, that's all we wanted to share with you. Thank you so much. It has been an honor to be part of this group and organizing symposium this year. I want to ask for your support to present more work. Next year, there's a wide diversity in the presentation of these works. Thank you. Thank you so much, Dr. Rivera. And with this, we are just about to conclude. And this is just to start the closing ceremony. I am Dr. Treviña, and I'm in charge of innovation on health. I'm very pleased to be here with you today, to be with all of you. So, first of all, I'm going to introduce the Presidium. You have seen we have with us the General Secretary of Inter-American Social Security Conference, Mr. Álvaro Velarca. The head of Excellent Clinical Excellence, Dr. Medina Chavez. So you have seen the head of Free Works, Monica Rivera. And I think who are the soul and heart of this Congress, that's why they are here with us. And at the end, but not so important, the coordinator for institutional HIV, Dr. Bellañez. And our coordinator of clinical programs on clinical excellence, Dr. Ivan Martinez Abarca. So, well, before we start giving them the floor, I would like to mention those who made possible this Congress. First of all, of course, the Inter-American Social Security Conference. First thing is to thank not only people who are here, but definitely people who made the most important work are the soul and the heart of this Congress. And I mentioned them. There is also some work going back, and on behalf of this Noé Rizzo, he is representing the conference, the Inter-American Conference, Social Security. Vanessa Stoer, MS. Fabiola Bautista. Just to mention a few of them. On behalf of Coordination of Epidemiological Surveillance, Dr. Monica Rivera. They are not here, maybe with us, Dr. Adriana Toriz. We send you some greetings. And also a cornerstone of the coordination of free works, Doctora Rosario Niebla. And much more people on behalf of coordination of social communication. It was the work of all people from the coordination, and we sent greetings, and I'm sure that he's seeing us, is Jonathan Orozco. So we send you a warm embrace. And on behalf of the Clinical Excellence Division, Dr. Humberto Medina, you've seen here. On behalf of the Innovation on Health, Saudade Lustres, Maestro Antonio Reina, Mr. Ismael Osada, Ana Karen Sarmiento, and also on behalf of coordination, and I hope that you are watching us, it was a core part for this committee of organization, Yomar Velázquez, PhD, or I'm MS. On behalf of course, we have to thank all this encouragement that has been given from top authorities for this organization, Mr. Robledo, first of all, but also Dr. Celia Duque Molina, and of course, we have to mention and greet Dr. Xochitl Romero and Gaby Borrallo. I'm sure that they are watching us. Without their cooperation, no program, no Congress might go for. And we are so lucky to have you all and the virtual presence of some of them. And I would like to leave at the end this wonderful team of the Division of Clinical Excellence and Special Programs. I am very honored to participate with this team, which is wonderful, that is being made by Brenda Rios, Luis Alberto Perez, Guadalupe Estrada, and of course, Alfonso Vega and Ivan Martinez Zavala. Now, this is just a small part of what is being done at the coordination. And now I would like to start by giving you a number, 5,500 people enrolled, and 4,449 were following us online. We had also up to 7,000 people at the same time watching and following your presentations. But seeing your work online, streaming, and so be sure that from this moment, you are impacting on the changes that might take place into the future. Something that matters is that only 53% of the audience were doctors, and this is important because that means that by following society and institution together to reach a goal, 47% is very significant. We're coming from other specialties, from other professions, and of course, the organization of civil society. In that sense, I am very pleased to see people that are so dear, so also liked by everyone. They have given ideas, good ideas, to keep on this work that we are doing, how to implement this program. with your views, with your vision. What is it missing? What is where we should go for? They are the link with so many users to realize that, of course, this is not perfect. It might be improved. So we will keep on doing that and working on that. I'm just going to mention some of them because they are here, but I'm going to tell them all. Luis Adrianes, Migueles, and all these people as representatives of this big community, I will say, of our dear people who live with HIV and people who look and seek to prevent this disease. Thank you so much. You are the soul, and you are our reason of being, our encouragement to do this type of events and to improve your care. Thank you so much from my heart, and because of your opinions, good, bad, whatever, complaints, whatever. This is giving us some way to go and let us know where to go forward. And I will complete my message. I'm going to mention that that's the slogan that we have for the event for 2024 is, and it's right here, commitment, share commitments for effective actions. You are all invited for next year. You will receive an invitation for that Congress, and we will have 23 keynote meetings, and we have pre-Congress presentations, and professors that, of course, this is a thank for them, are with us today, including countries as UK, USA, Argentina, Cuba, Peru, Brazil, Dominican Republic, Chile, Costa Rica, El Salvador, Belize. Most of them are attending here in person. If not, they are also invited for next year. With this, I want to welcome, and I am so grateful to you, to my wonderful team, and I have to use this type of saying because these are the people who make this possible. It has been a privilege for me to work with you in this Congress and in general. So I give the floor now to Álvaro Velarca, so for his final mention and the closing words for this Congress. Thank you so much, Sandra. And well, I start by conveying giving some greetings from the chairman of the president of this conference, Mr. Aburtos, this general director of the Social Security Institute. I am so sure that he will be very pleased to know this great number that has been shared by Sandra, and I add up to this acknowledgement that Sandra is doing about this team of the Social Security Institute that has been participating so enthusiastically, and I would like to thank Dr. Monica. You have been so enthusiastic, so committed with the studies. Humberto, and of course Sandra, Alfonso, Ivan, and Dr. Celia Duque, Gabriela Borrallo, and I want to end up by mentioning all people who had been doing their best for this Congress. And the team of the Inter-American Social Security Conference, I am so pleased and proud that in these 2 years, more than 2 years, that we are working together on this branch of HIV. Well, I guess that more than partners, I have a group of activists who had been involved so much and so fully on HIV. It's very satisfactory that they can do so. So thank you so much for that, Noé, Vanessa, Miguel, and all of you, all who are part of this team of the conference. And Sandra was mentioning before about the number of people, also the conferences and the people who had been with us, but and the key speakers, but we keynote speakers. We have been able to know through these presentations, it's been possible to know more about the situation of each one of the countries of the American continent in regards to treatment and care of HIV and the gap there is to meet the commitments that we have for 2030, the strategies, the efforts made, and especially challenges. How we are doing, what is it missing to reach 2030? Because I do insist, as I was saying before, it is possible to to stop the transmission of HIV. We know the way how to do it, and some countries have done that. I'm sure we are taking the right route. So this Congress makes us think very pleased. We have been given visibility to treatment, to care of HIV that just in few times it has been possible to do so, to fight HIV in our region. So we are learning now to see, to consider HIV as a common problem, common issue. Sandra was saying, how is it going to be the slogan of next year? These are shared commitments. This is an issue that is common, that we matter about it. And it's something related to us, to all the people of this American continent. This is a shared challenge of all the countries that make up America and of this continent. So I don't want to take more of your time and talk about figures. I guess that we already know about the figures. But I want to remind you to make a summary of the most important topics we have seen during this Congress. The use of these models, epidemiological models with different epidemiological models that might be adjusted to our region, to our special situation as means of transmission. This is a model that has been used in 3 countries, in other countries of the continent, Dominican Republic, Peru, Mexico. And this is a model that might be useful in order to have a better estimate of our goal to reach 95% of people who live with HIV, to know about the status and the use of key medication drugs to reach these goals, self-test and PrEP and PEP. And finally, the partnership with civil society. This is key. I think that nobody finds it as a secret that these organizations of civil society are the ones who are the eyes, the ears of what is happening around us in the street, in the cities, and they are the channels of communication. So we need to acknowledge and to thank all of you who have been working in this effort. And Luis Adrian, thank you very much for being here with us today on this battle. Well, I'm very pleased. I want to thank you, but not without acknowledging those who had been the heart, the brain, and the hands and the feet, and everything in this Congress. And since a long, long time ago, in the treatment of HIV at the IMSS. Sandra, she is so committed, and we do not only acknowledge this big involvement and commitment, and happy birthday, by the way.
Y así siendo las 17 horas.
At 5 o'clock on November 30th, I declare officially closed the works of this Congress. It was necessary to stand up. Okay? Still is 5 o'clock, and I formally consider close this International Congress for the attention of and care of HIV. Thank you so much, all of you.
So let's remain standing. We are going to broadcast the IMSS anthem.
El águila, una madre y su regazo, son símbolos de un amor indeclinable a un pueblo que avanza infatigable con rumbo al porvenir, nunca al ocaso. El ave da su mirada enternecida al fruto que se protege frente al pecho. La madre cubre al niño sobre un lecho que es amor, patria querida. Con sus alas generosa nos abraza. Mi pueblo yace vivo en su plumaje. El ave con orgullo y con coraje siempre vigilará por nuestra raza. Instituto Mexicano del Seguro Social, ave plena, madre digna, hogar del sol. Instituto Mexicano del Seguro Social, ave plena, madre digna, tu hijo yo soy. Instituto Mexicano del Seguro Social, ave plena, madre digna, hogar del sol. Instituto Mexicano del Seguro Social, ave plena, madre digna, tu hijo yo soy.
80 años. 80 years IMSS.